and wish you all the very best for today's deliberation. And I'm sure this will set us in the right direction to become, again, we are the world, you are the world leaders in medical education with 612 colleges and over 120,000 teaching faculty, medical teaching faculty, who need your help, need to bring in evidence-based teaching and then become another world power, the true place. Because I've made this known to Judy, to all the others there, even before we started this program with AMEE, or even before FAMA, the graduates from the medical colleges in this country are running the NHS in UK. Quote Lord Stevens, NHS CEO, at a meeting, he mentioned that. So you already are playing a role in the world. And I just think this will add credibility and value to not only those who are teaching, going to work in the other countries, but to this, our country, this country, right? So for that reason, I'm here with you today, come from Australia to attend this in person, not virtually. So thank you all very much for giving me this opportunity.
Thank you so much, sir. We feel really privileged to have your presence.
Thank you, sir. With this, let us move forward towards scientific session of the CME. For the first session, which will be focusing on Introduction to Sustainable Developmental Goal, SDG 4, Components of Quality in Health Professions, Education and Related Perspective by Dr. Kirtana Nayak, I'm pleased to invite Dr. Jayaraj D. Pandian, Principal and Professor of Neurology, Vice President of World Stroke Organization, President of Indian Stroke Association from Christian Medical College, Ludhiana, Punjab, India. He will be joining us virtually. And Dr. Alka Ravekar, who is Professor and Head, Department of Physiology, JNMC, Convener, PhD Cell, DMIMSDU, Co-Convener, NMC Nodal Center, JNMC, Ex-Dean Allied Health Sciences, Savangi, Vardha. Please chair this session.
Yeah. Thank you very much. I just want to know Dr. Alka Ravekar is there. Hello, good morning. Yeah, good morning,
yes, the ma'am has joined as chairperson with us.
Yeah, okay.
Yes, yes, I'm here, sir. I'm here.
Yeah, thank you. It's a great day for India in the field of medical education, as Dr. Russell D. Souza mentioned about the contribution of India, not only at the country level, but also at the international level in the field of medical education. And it's a great honor for our country, for the Association of Medical Education in Europe to inaugurate 4 nodal centers in our country, and it's a great moment for all of us. So without any delay, I will request Dr. Kirtana Nayak to talk about the components of quality in health professional education and related perspectives based on the SDG 4. Yeah.
May I please have some introduction of Dr. Kirtana? Dr. Kirtana is Professor of Physiology and Head of the Department of Medical Education at Kasturba Medical College, Manipal. After completing her MD in Physiology, she has been now working at KMC Manipal for last 15 years. She has served as Professor and Head of the Department of Physiology from 2015 to 2020. Her areas of interest and expertise include neuroelectrophysiology, teaching innovations in medical education, and she is currently the convener of NMC Regional Center for RBME TPG at KMC Manipal. She has got multiple awards. Her summary of scientific career includes some key achievements, as she is associated with academia industry collaboration She is associated with autonomic function testing laboratory, which has been set up in the Department of Physiology, KMC, Manipal. She has been guide for multiple PhD projects. She has multiple awards from DST, CSRI, grant, etc. I welcome Dr. Kirtana to have your deliberations on the topic Introduction to SJD4, Components of Quality in Health Profession Education and Related Perspective. Over to Dr. Kirtana.
Thank you. Welcome, ma'am. Warm wishes and a very good morning. It's pleasant to be at Datta AMEE Medical College, Nagpur. It's my first visit to Nagpur. I am Dr. Kirtana, Professor of Physiology, Head at Department of Medical Education at Kasturba Medical College, Manipal. I work for Kasturba Medical College, Manipal, and our university is Manipal Academy of Higher Education, Mahe, Manipal. Recently, we are graded A++ by the NAC assessment. We have two other colleges under our university. We have a Kasturba Medical College at Mangalore, and we have a recent addition at Jamshedpur, the Manipal Tata Medical College. So together we have 650 annual admissions at these three centers. We have a medical university at Sikkim and we have one at Malaysia. So Department of Medical Education, Kasturba Medical College, Manipal has history of having started the medical education department way back in 1985. And currently we are a recognized NMC regional center for RBCWPG from 2021. So together with our adjunct and our resource faculty, we conduct NMC mandated workshops. We have several other programs and we conduct oration awards also as annual feature. Sustainable Development Goal, SDG 4, it stands for ensuring inclusive and equitable quality education and lifelong learning opportunities for all. And this is applicable to all realms of education, whether it's primary or higher education setting. The most influential analytical framework for quality of assessment in healthcare says healthcare delivery should be safe, effective, patient-centered, timely, efficient, and equitable. By safe, it means to avoid any harm to the patient. Effective means to provide care based on scientific evidence. Patient-centered means providing care being respectful and responsive to the patient needs. Timely means to reduce any harmful delay and wait. Efficient means to make judicious use of healthcare resources. And equitable means the healthcare should reach everyone regardless of identity or social status. So while training next generation of doctors, we have got to bear in mind that these attributes are acquired as part of competencies during their training and graduates will be able to deliver them during practice. So integrating quality is founded on the principle that clinical excellence, patient safety, and quality improvement in education are all essential. And they're essentially linked to high quality healthcare, meaning high quality healthcare is possible only by quality improvement in medical education. While we stringently follow evidence-based medicine in clinical practice, so was not the case or not the case even now to the practice of medical education, because the practice of medical education, there is variation between the country, within the country, there is variation. So the practice of medical education is influenced by the long history of teaching tradition, the cultural and socioeconomic conditions, health and disease spectrum, there are regional differences, and healthcare delivery system is unique to each country. So notwithstanding these variation, there needs to be equivalence, whether it comes to structure, process, definitely with the product of medical education. And that's possible because the World Federation of Medical Education, the umbrella organization, they have put forth the global standards for ensuring the uniformity of quality across the medical programs and schools. So World Federation of Medical Education has put forth these global standards, and they're not equivalent to the global curriculum. These are in fact a framework of standards in 8 principal areas, and they are not prescriptive. They are not process-based. They are a principle-based, so that regulatory agencies or individual schools can contextualize based on their local needs, based on the WFME standards. So these standards have been put forth with 3 main intentions. First one is medical schools will be able to formulate their own plans for quality improvement, but well within the international recommendations. Second one is to establish a system of national and international evaluation for medical schools to have minimum quality in their medical programs, to safeguard the practice of medicine and increasing internationalization by well-defined standards of medical education. So these standards have been spelled out in 8 different areas in BME, the basic medical education. Similarly, the standards have been defined for postgraduate medical education as well as for continuing professional development. So what I will do in my rest of my presentation is I'll touch and pass through the 8 areas in the basic medical education. And together these 3 are called as the WFME trilogy. So coming to the first criteria, the criteria that I will take first is curriculum and content. So curriculum and content forms the heart of any education program. So what does the curriculum cover? Does it include essential elements such as basic biomedical sciences, clinical sciences, behavioral sciences, social sciences? What are the efforts made by the school to teach humanities? Equally important is the process in medical education. Learner centricity is the mantra in any stream of education today. So what are the desirable practices adopted by the school for training student doctors? Are the outcomes clearly defined? What are you teaching? Is that defined by outcomes? What is the curricular organization? What is a model of integration? Does the school have mechanisms to conduct online, distributive, or distance learning? Is there a curriculum committee making decisions related to planning, implementation, evaluation, and feedback? These questions, if attempted to answer, will guide a university or a school to meet the criteria on curriculum. So the next criteria I would take is assessment. So does the school have policy on assessment? What is the relationship between formative and summative assessment? Is the assessment based for useful, actionable feedback for learners? Is the data on assessment used for improving the performance of the staff, the course, the program as a whole? How do you measure attainment of competencies? So that's the criteria on assessment. So moving to the criteria on standards, admission, at least in our country, is governed by the national policy. But how does the university or school support students regarding their mental health, physical health? Is there a career guidance cell? How does the school assist students regarding financial and academic related matters? So answering these questions are essential to meet the criteria on students. So moving on to academic staff. Are there adequate academic staff to deliver the curriculum efficiently? How frequently are they undergoing training? How does the university and school support with faculty development programs and training? And how much does the university support scholarship of teaching? That's very important, scholarship of teaching. And how does the university recognize academic activities? Coming to the educational resources, is there sufficient physical infrastructure? Are our students getting exposed to all levels of healthcare, primary, secondary, and tertiary levels of working of healthcare? Are students having adequate access to both physical as well as virtual information resources? What is a policy that fosters a relationship between research and education? Is there a skills lab to train students for skills? So answering these questions would guide universities towards satisfying the criteria on educational resources. So coming to the criteria on quality control, governance, mission, and values, is there a school level system for quality assurance? Is the school involving external stakeholders? So in addition to mandatory National Medical Commission accreditation, does the school involve, there are several other ranking agencies now, there is NIRF, there is NAC. What is the governance structure in relation to teaching, learning, resource, and research allocation in line with mission and values? So this has covered the 8 principal areas in basic medical education. So what I have come to understand from the WFME standards or the European adaptation is that the newly introduced competency-based undergraduate curriculum, whether it's foundation course, whether it's electives, whether it is student doctor method of training, the need for a curriculum committee, the need for a skills lab, all these are enshrining the principles these quality indicators measure. So why ensuring quality by quality assurance across medical schools, we see that the doctors who are graduating, they'll be prepared for the needs and expectations of the society. The graduates will be able to cope with explosion in medical scientific knowledge and technology. The physicians who are graduating out will be having lifelong learning skills, and the medical education will be able to adjust to the changing conditions in healthcare system and delivery. So thank you all for patient hearing, and a big thank you to Ved Prakash Mishra sir and team for hosting the National AMEE India launch. So thank you, everyone.
Thank you, Dr. Kirtana. It was really an informative and meaningful deliberations where she appraised the audience regarding SDG4. She tried to connect the trilogy of WFME with the mission of AMEE. Not only this, she elaborated on why the quality in medical education is necessary. May I ask the audience if you have got any questions or query regarding the topic? Yes.
That the present CBME that we have structured and that we have rolled out from the year 2019, and we will be generating the first batch in 22-23. In terms of the operational mandate and in terms of the modes and modalities that we are availing to a structured program across the country, where exactly we will be in terms of conformity with the WFME guidelines, 8 standards, and to what extent we think that this will enable the entire CBME program and the graduates thereof to sustainably cater to SDG4. Because the model that we have taken up is CBME. We will not be able to make any major alterations till the first batch comes out. I mean, this model is expected to be operationally staying at least for a period of 4.5 to 5 years. You can't alter the curriculum at the back of the learner. Even if there is any alteration which is required to be made, it will be made only when the first batch passes out. In that situation, these 5 years in the context of CBME, as to whether we will be in a position to say by July 2023 that we have stood the test to cater to SDG4, or there is any wanting in it.
Sir, I think hats off to the team which has built the CBME and rolled it out. I think
Let us congratulate each other.
each and every component in CBME, if we diligently implement and practice, I think we will be able to hit every area in the WFME criteria. So I
Thank
think
you.
that's it.
Yes, you please introduce yourself. Anna.
Yes, ma'am. I'm Dr. Anaga Sasrabuddhe from Department of Physiology. Ma'am, congratulations for your excellent presentation. And I would like to share what we are doing under this ambit of SDG 4 at our institute. I would like to share that with you. And I would also like you to give your inputs to improvise the things. So as far as the components of equitability and equality under SDG 4 are concerned, we have students from diverse backgrounds. And what we have done is we have made different clubs of these students based on their psychometric analysis. So we encourage them to pursue their hobbies and whatever skills and talents they have through co and extracurricular activities. We also have preceptorship program, which is highly successful, and then students can open up with their teachers and share their problems, difficulties, if there are any, in different areas like hostel related, study related, or anything which is outside curriculum. As far as skills are concerned, we have a very high fidelity virtual lab in our institute, which students will be utilizing for developing different skills. We are coming up with a central museum, one of its kind in central India. So that will be another trigger for our students to have a self-directed learning, which is a mother repository for life learning skills. Then we are also we are also conducting a peer-to-peer teaching learning sessions, which are very well received by the students. Research is our very strong forte. More than 60% of our students are involved in research-related activities right from first year. So this is all I want to share what we are doing. And ma'am, I would like your expert opinion how to
I
improvise on
think
this.
you're already doing lots. So only area I think what I can give you feedback is involve as many students as possible in committees and then take feedback from them and then document that and base actions on that feedback. Yeah.
Thank you. Thank you, Anaga. Anybody
Thank
else
you,
from the audience?
Yeah, can I make a comment?
Yes, please, please.
Yeah, so thank you very much for elaborating about the standards, the BME standards in medical education and comparing with the CBME. It's a great effort from NMC to roll out this new curriculum based on CBME. What has happened is there are many nodal centers and they are able to train the faculty across the country. But the ground level implementation, it has not been equal. There are many medical colleges who have implemented all the parameters and the modules of CBME, but many other colleges are still lagging behind. So that is another thing that, as Dr. Mishra had mentioned, we can relook at in 2023 when the first batch comes out. And then I think further fine tuning would be needed based on the feedback that we receive.
And I have most of this
CBME program is not being diligently, as you said, being practiced in the clinical side. This is what I have noticed through my wherever I go around and see. It's not being implemented in the clinical side. So this is the feedback I have.
That's
How do you do it? The clinician teaching their undergraduate as well as postgraduate.
so frequent meetings with the clinical departments, taking small steps, sharing best practices from other departments. So these are few things which we are currently doing. But one good thing in Manipal, what we started was we started ADCOM even before NMC had implemented. So we have a 6-7 years of practicing ADCOM even with the traditional program. we had a skills laboratory and the students were trained at skills even before CBME. But having said that, we find logistic issues when we teach small groups because we need more manpower. So there are still few issues. I think we will need few more years to streamline and in principle practice it in clinical years. Sure, ma'am, that's right.
All the experiences, NTT days, recall early, mid 80s and early 90s. You will be finding the statistics revealed, 1994 Government of India Health Ministry statistics reveals that of the total faculty trained by NTT during a period of 11 years from the point of its launch, the number of professors were only 3% of the total number of faculty trained. The clinical teachers percentage was 1.04% of the total faculty trained. And the bulk of the faculty which was trained was from preclinical, even paraclinical was not in that abundance. So you're right, that gap is there. But the only modality, and that was the reason why National Faculty Development Program was conceived. The aim is that 100% of the faculty needs to be oriented with handling of the entire structure of teaching learning as contemplated in CBME without any exception. And therefore, it is only that modality which will work. What Dr. Pandian has put across is there is a huge divide, ma'am. There are colleges which are doing extraordinarily, and there are colleges and institutions which practically are non-starters even today. So that leveraging is expected to be difficult. The real issue that we need to face is, see, WFME, the WHO hitherto picks up the institutions which are appropriately accredited. But imagine 612 medical colleges today. In 2023, if people will be picking up only say 100 and 150, what will be the fate of remaining 450 medical schools in this country, which will be absolutely outside the WHO directory? And that is the magnitude of the problem which all of us have to think on. It's not just the institutional excellence which is going to fetch us dividends. We will have to ensure that we are in a position to put across all colleges on an equal level playing field, whereby on 31st of July 2023, practically every medical college in this country will be included in the WHO directory, and that will be a landmark, because then highest number of medical schools in the WHO directory included will be yours and mine in India, and that is exactly you and me will be the superpower in the world. That is what I'm working towards. Yeah.
Thank you, ma'am. Anybody else from the audience? Okay, thank you so much.
Thanks, Dr.
Thank you, Dr.
Thank you.
Thank you, Dr. Kirtana Nayak. Must say a star from the galaxy of medical education for imparting your precious knowledge with us. Thank you, Dr. Jairaj D. Pandian, sir, and Dr. Alka Ravekar, ma'am, for chairing the session. Thank you, ma'am.
Jairaj, are you able to hear me?
Yeah, I can hear. Yeah, thank you very
All
much.
well, all well.
Yeah, it's 2 a.m. in Sao Paulo, so I'm going to sleep. Thank you. Bye.
I'm pleased to invite Dr. Alka Ravekar, ma'am, to felicitate our speaker, Dr. Kirtana Nayak, with memento as a token of love and appreciation.
कितना सेंटर में आओ, हल्का सेंटर में. हाँ. कैरी बैग लेके कैरी बैग में लो.
Dr. Jairaj D. Pandian, sir, will be felicitated virtually. I request Dr. Anaga Sahasrabuddhe, Associate Professor, Associate Professor, Department of Physiology, to felicitate our chairperson, Dr. Alka Ravekar.
Very bad, get it. Good.
Thank you, ma'am.
Moving to next session on Beyond Campus Training, Professionalism, Lifelong Learning Skills by Dr. S. Krishna Mohan. I'm pleased to invite Dr. Mary Matthew, Professor and Head of Pathology at Kasturba Medical College, Manipal, with more than 25 years of experience and specialization in renal and pediatric pathology. She'll be with us on virtual platform. And other chairperson for this session, Dr. Sunita Wagh, Dean D. Academics, Faculty of Medicine, Professor and Head Pathology, Jawaharlal Nehru Medical College, DMIMSDU, Savangi, Wardha. I invite both the chairpersons to chair this session. Over to you, madam.
Thank you, Shweta. I hope Mary Madam has joined.
Yes, thank you, Dr. Sunita. I'm online, but my video is not functioning, but I'll be here. I'm here in online. Thank you.
So thank you. I invite Dr. Krishna Mohan. Dr. Krishna Mohan is a lead faculty for AMEE Center. I invite him for the next lecture. Specialization of Dr. Krishna Mohan is the field of medical education and health profession education. Basically, he is a faculty of medical biochemistry. He is also specialized in bioethics, public health informatics, population health informatics, clinical skills, simulation, operational research in population health, assessment, accreditation, and quality. Presently, he is Vice Principal and Professor Biochemistry and Molecular Biology, Head Department of Medical Education and MEU Coordinator, Head Bioethics Units. There means if I go on reading his CV, there are n number of publications to his credit, more than 200 research publications in various journals. His citation index is very good. So I invite Dr. Krishna Mohan to deliver his lecture on the Beyond Campus Training. Krishna Mohan, please.
Thank you very much, ma'am, for that kind introduction. And thank you very much, sir, for giving me this opportunity, Dr. Russell and Dr. Prakash Mishra. And thank you for all the dignitaries on the dais and off the dais. I think Dr. Kirtana has set up the stage for my talk. And I'm going to talk about the Beyond Campus Training, the professionalism and lifelong learning skills. So what I want to do is I don't want it to be a didactic session. So ours is a new medical college, we got LOP in 2021 for the academic year for the admission of 150 students. And we all feel that new medical college means there will be n number of obstructions. And also we were disrupted by the COVID during that time. But still, we have taken this as an opportunity, and we could start the medical school with the first batch of 150 students admitting in academic year 2021. That is, we admitted the students in February 2021 with a good start. And we have started the medical school with a few innovations. And also I wanted to share those innovations and our experiences related to the beyond campus training, so that as co-learners, I wanted to, we all can discuss, and I want also to gain your opinion and expert opinions, as well as we can discuss on that. So disclosures, I don't have any financial interest with any company and nothing to declare, and there is no conflict of interest. And the specific learning objectives for my session is, by the end of this session, the participants will be able to, I call you all as a co-learners rather than the participants, appreciate various strategies to foster professionalism and lifelong learning skills in the health professional education. And truly, I'll stick on to this objective. I'll just give the glimpse of the professionalism, how to incorporate the teaching of the professionalism, and also how to assess the professionalism. And then what are the components with related to the CBME. And because it's health professional education, I want to bring in the other health professional curricula also, like the CBME, which is going to be rolled out very soon. And then I wanted to share our experiences in Bangalore Medical College with respect to the beyond campus training. So the professional competence is nothing but the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. It's defined as a set of values, behaviors, and relationships that underpin the trust of the public has in the doctors. That means that the profession is having the contract to the society. The American Board of Internal Medicine has identified altruism, accountability, duty, excellence, honor, integrity, and respect for others as the key elements of the professionalism. Whereas the Royal College of Physicians, UK, has identified the integrity, compassion, altruism, continuous improvement, excellence, and collaboration with the colleagues as the key elements of the professionalism. The Charter on Professionalism have identified three fundamental principles of the professionalism. Number one, the primacy of patient welfare. Number two, patient autonomy. And number three, social justice. The first principle, the primacy of patient welfare, brings in the altruism, brings in the justice, brings in the trust. And the second principle of the professionalism, the patient autonomy, brings in the honesty with the patients. And also it emphasizes the need for the empowering and educating the patients for taking the right decisions or the appropriate medical decisions. Social justice is the third principle of the professionalism, which emphasizes or brings in the aspect of the societal contract along with the distributive justice. The responsibilities of the professionalism include commitment to the professional competence, commitment to the honesty with patients, commitment to patient confidentiality, commitment to maintaining appropriate relations with patients, commitment to improving quality of care, commitment to access to care, improving access to care, commitment to a just distribution of finite resources, scientific knowledge, commitment to maintaining trust by managing conflicts of interest, and commitment to professional responsibilities. So why is it important? The importance of the professionalism lies in with regard to the patient, their safety, their security, and ultimately achieving the positive health outcomes. So when the patient comes to us or any physician with the suffering, we always tend to take two important actions. Number one, it can be one is the right action and the other one is good action. So that the right action in the context of identifying or implementing or taking the best evidence-based and the scientifically available clinical decision. Whereas the good action with related to the healing, or it's also called as good healing action, is related to the patient values. It's related to the patient preferences that plays a key role in bringing the positive health outcomes. How will we teach or how will we incorporate the professionalism into the teaching learning process? By virtue of the interactive lectures and brainstorming, by using the clinical scenarios or the case vignettes, by using the reflective exercises, by giving the constructive feedback and the timely feedback, portfolios, role modeling, and also by using the art-based interventions. So how will you measure? Because the professionalism is all about the values. So like any other domain, in the domain of the professionalism also, an individual's competency is measured by how they demonstrate the knowledge, the skills, and the attitudes or the abilities in the domain of the professionalism. These are all the assessment strategies by using all the phases of the Miller pyramid. That is, in the domain of the professionalism, you can also assess knows the knowledge component, knows how the competence, shows how the performance does is related to the action, and how he demonstrates in the clinical settings once he starts the practicing. That is about the identity. So all these assessment strategies can happen in different settings. For example, knows how you wanted to test the knowledge component. It can happen in the group discussions, and so that you wanted to check the knowledge whether, because the knowledge is the base. That is why it has been kept on the base of the Miller's pyramid, but yet it cannot be ignored because you are assessing the knowledge component. Because if the children are not able to know what is the professionalism, then they will not be able to demonstrate the professionalism or the values related to the professionalism. So when it comes to the assessment of the professionalism or the measurement of the professionalism, the challenge lies in, because you wanted to assess the values. Actually, it is quite challenging or difficult to assess the values or to measure the values, because they are not observable and they are not measurable. So it's always, but on contrast, behaviors can be observable and measurable. So the professionalism can be best measured or assessed by linking the professionalism values to the specific behaviors. So, and another challenging task in measurement of the professionalism is, it is apart from the knowledge domain, apart from the cognitive skills, the competency in professionalism also involves the non-cognitive skills like communication, collaboration, and continuous improvement. So communication can include the language, integrity, then compassion, empathy, then collaboration. It includes the respect, the responsibility, and also the duty. Then continuous improvement, accepting the pitfalls, and also showing the commitment for the improvement. So this is how the values can be linked to the specific behaviors. For example, responsibility, it's a value. It can be linked to the behavior that is follows through on tasks, arrives on time. So these behaviors can be measurable and also observable, so that you can, and also these behaviors are bringing the feedback component. So by looking at them, by observing the children, whether they're behaving properly or not, as per the SOPs, then what you have to do is you have to give the feedback to them. That means that ultimately you're going and giving the feedback about their values, because whenever you wanted to talk about the values to anybody, they will not be accepting, because it's a threatening environment. So if you say somebody you are irresponsible, they will not accept. You have to tell them in what way you are irresponsible. Or for example, a child has an intern has written the prescription or the diagnostic test, then they have gone to the lab, but they are not able to get it in the right time. So that has reflected on the quality treatment of the patient. So you have to call them and tell them that, look, this is what has happened because of the delay in the lab report. You have not taken the responsibility of bringing the lab reports in the right time. So then you are giving the constructive feedback so that they will be able to take it in a positive manner, and then they will be able to demonstrate the right value next time. So that is what is the importance of the linking of values to the specific behaviors. When it comes to the value maturity, the linked behaviors are accepts blame for the failure, does not make inappropriate demands, is not abusive and critical in times of stress. Then coming to the communication skills, listens well, is not hostile, derogatory, sarcastic, is not loud or disruptive. If you look at all these behaviors, they're observable as well as the measurable. Respect, maintains the patient confidentiality, is patient, is sensitive to physical or emotional needs, and is not biased or discriminatory. So when you look at all this, the professionalism and all this, the domain, the lifelong learning, lifelong learning is an integral component of acquiring the professional values. So what is lifelong learning? It can be defined as the learning that is pursued throughout life, learning that is flexible, diverse, and available at different times and in different places. The WHO has defined the lifelong learning as the abilities for adaptive and positive behavior that enable individuals to deal effectively with the demands and challenges of everyday life. So the WHO has identified 10 core skills as the lifelong learning skills. Number 1, problem solving. Number 2, critical thinking. Number 3, effective communication skills. 4, decision making. 5, creative thinking. 6, interpersonal relationship skills. 7, self-awareness building skills. 8, empathy. 9, coping with stress and coping with the emotions. So if you look at the role of IMG, which has been put up by the Graduate Medical Education 2017, they have described the roles of IMG as the clinician, leader and member of the healthcare team and the system, communicator, lifelong learner, and the professional. So all this professionalism, the core skills that are related to the professionalism and the lifelong learning skills have been already incorporated. So our product has to be like this. And we all know the CBME and the to be rolled out the CBNE has incorporated the key components and integrated the professionalism and lifelong learning skills into the curriculum. And also, if you look at the AdCom module under, they have incorporated 54 competencies with the 27 modules and the phase-wise manner, starting from first profession to the fourth profession. So, as we already discussed during the deliberations in the first session, the success only lies in how well we implement. It's all depends upon us, we the faculty. So we all have to get trained and we all have to come out of the comfort zone of always delivering the lectures. And then if you are able to understand the essence of the CBME, then definitely we are able to really produce the IMG with the said characteristics. Now, so anyway, all these professionalism and the lifelong learning skills have been integrated into the CBME as well as the curricula of the other competency-based curricula of the other health professions education. Now, anyway, we will implement all these things, but only thing is how well. But at one point of time, all of us will reach the best level by the efforts of the NMC, the faculty development, the pace or the way at the speed at which the faculty development programs are undergoing. So definitely all the medical colleges in India at one point of level will be able to excel. But the question is, to accomplish the SDG 4, we have to plan the activities beyond the campus training. So with respect to the professionalism and lifelong learning skills, even though ours is a new medical college, the Panimula group of institutions in Chennai are the pioneers in the engineering education. They have their own legacy for last 20 to 25 years. So when they wanted to enter into the medical education or the health profession education, so they wanted to maintain the same legacy in the medical education field or the health profession education also. So we have started both the colleges, the medical college as well as the nursing college, and 150 students have been admitted for the academic year 2021 in the medical college, and 100 students are admitted in the nursing college for the academic year 2021. So when being the vice principal and all our dean or the administrators and being the MEU coordinator, we have given a big responsibility to make sure that their legacy in the engineering college education has been transformed into the medical also. They wanted to be known for that. So we were thinking, the first challenge is we wanted to implement the CBME exactly without any deviation. And we are happy that in 2019-20 only the CBME has been rolled out. We are the second batch. So what we have done is first we have identified, at least in the preclinical and paraclinical departments, we have taken all the faculty who have undergone at least the revised basic course workshop. And many of them have done the ACME also, or few of them have been trained in the FAMA. So it was very easy for us to implement the CBME, and I want to place it on the record that we have implemented very well. I think then SRMC will be able to acknowledge our efforts because we have submitted all the documents and the activities to you, madam. Now, the second one again, from the management perspective, we want it to be different. We want to bring in value-added education to the children who are joining in the Panimula Medical College Hospital Research. So what we have done is, the first thing that we have done is we have contacted Dr. Russell D'Souza to train all our faculty to get trained in the ethics. They are running the certificate course. And I'm very happy to inform you all that 100% of our faculty have been trained in the certificate course in the ethics, both preclinical, paraclinical, and clinical, because the management has taken the decision that everybody have to undergo the ethics curriculum. So that is one. Then most of us, we have progressed into the postgraduate diploma also. And few of us, once we complete, we were into the master's also. That's first thing we have done with related to the faculty development program. Second, we wanted to train all our faculty with regard to the medical education RBCW, but it took some time because the NMC has organized, reorganizing the structure of the RCs and INCs and all. And recently we were attached to our NMC has inspected through CMC Ludhiana. Our MEU has been inspected and it's been approved, and we were allotted to the regional center, that is Madras Medical College. So now we will also send our faculty for the faculty development program in the medical education. Then again, we wanted to do something value addition to our children beyond the curriculum. So again, I have requested Dr. Russell D'Souza, and we have had a very long talk, and I think Dr. Ved Prakash Mishra sir also has been a part of it. And because of their deliberation and because of their conceptualization, they have come up with a course called as International Foundation Course on Moral Values, Bioethics, Professionalism, and Personal Well-being for the first year medical students. Not only for the first year medical students, it is also has been conceptualized for the first year nursing students also. One important thing that we have kept in our mind is we wanted to do all these things, bring in all these things from the day one, because the students are not having the seniors, right? They're fresh. So we wanted to make it as a habituated, and we want to make it as a regular practice into in our colleges, both the colleges. And it's been a concept, and it's not only about the moral values, bioethics, professionalism, and its more important thing is the personal well-being concept has been added into this, because most of in the health professional education, they are all with so much of stress. So we wanted the children to cope up with the stress, as we have already seen in the professionalism, responsibilities, and the competencies. So it has been incorporated by them. And the course will have around 36 lecture hours, or I don't call it as a lectures. It is weekly once online by Zoom. All the faculty from the international level, all the stalwarts in the ethics, the deans of the various medical schools and various nursing schools used to come and teach our children. And I'm glad tell you that Dr. Ved Prakash Mishra sir also have taken sessions for the nursing students as well as the medical students on the moral values. And yesterday also we have one session on the duty of candor. Okay, Professor Brian Revnan from the University of Newcastle has taken. And you could see the interaction by the students. We will think that it's not about the science. Science anyway, they will learn anatomy, physiology, biochemistry, and all those things. It's all about more than that, ethics, moral values, and all. And 6 o'clock it started, and it has to end by 7 o'clock. And until 7:30, the children were interacting with them with respect to the duty of candor, right? So that is what is that we could see how the students are taking up this. And this course consists of the two semesters, semester 1, bioethics, human dignity, human rights in healthcare, the UDBHR curriculum, and semester 2, foundation to moral values, ethics, professionalism, and personal well-being curriculum. The unique feature, sir, is the true andragogy. We are introducing the self-directed learning principles by virtue of this, we are introducing to the students. It's flexible, and there is no threatening environment. It's a non-threatening environment, because none of the stalwarts will use that they are the teachers. They always say that they are the co-learners. That makes the stage set up to the children to interact with them, to develop their communication skills. And not only that, by looking at them, by listening to them, they are taking them as the role models. Role modeling is coming into the picture. And it's synchronous and asynchronous learning. We have created the Google Classrooms, so that if at all a child misses the one session, they can always go back. But even though the asynchronous learning is available, I wanted to make it on the record that until now, we have been introduced for 2 batches. More than 90% of the attendance has been there for all the synchronous sessions. Weekly interactive lectures, Google Classroom, mentorship, experiential learning. They can discuss on many cases, and few assignments will be given. Again, there is no threatening environment, because they are all the formative assessments. There is no summative evaluation, and dedicated WhatsApp group was there wherein the children can interact with all the faculty across the globe. And these are the glimpses of the course. Dr. Stacey Gallin is taking the class. Then this is Dr. Desmond Pohl, taking the class. And this is after each semester, we have a feedback session, and wherein all the faculty comes and discuss about what went well and what went wrong. The children will be interacting with them, and we will be implementing the feedback also. And we didn't stop with the first professional year alone. So again, we have requested back to Dr. Russell D'Souza. So he, along with his team, has conceptualized for the course for the second professional year also. In the second professional year, they will be talking about the AMEE Code of Ethics, and they'll be talking about the leadership. They'll be talking about the stress management. They'll be talking about the faculty talking about how to cope up with the failures. Dr. Shabir Amanullah from Canada has taken the session. And apart from this, the preclinical, paraclinical subjects, ethics of microbiology, ethics of pathology, ethics of pharmacology, all these things have been discussed. And apart from the ethics, because in our vision of the Peninsular Medical College as well as the nursing, we have integrated two components. One is ethics and the other one is the research. So again, we wanted to give an value addition, because you have the ethics, you have the professionalism, you have the lifelong learning skills, wherein all the reflective practice have been inculcated into the student. We also want them to know about the research and the basics of the research methodologies. So we have had a tie-up with the University of Memphis. Dr. Ashish Joshi, previously he was the associate dean for in the City University of New York. So he has kindly consented to design a curriculum. And the same way, the unique features are non-threatening environment, flexible learning. Every week they'll be having an online session by Dr. Joshi, and these are the glimpses of the sessions. And the same way how we have formulated the ethics curriculum, and we also have the first professional year. You have year-long course, foundation course in research methods. Second professional year, we are introducing them to the health informatics, because for the nursing students, we are introducing the nutrition health informatics, because we believe that the next decade or the next 20 years, the healthcare sector reforms will be mainly related to the digital health. So we also want them to get the competencies related to the digital health. And Dr. Ashish is preparing the curriculum for the third professional part 1 and part 2 also. And these are all the modules that have been discussed in the year 1. The basics of research methodologies, formulating a research question, defining hypothesis and study design, study methods and statistical analysis, interpretation of results, manuscript writing and submission. And year 2, for the medical students, applied health informatics was taught, and for nursing students, nutritional informatics has been taught. Again, the unique features of the course are flexible, synchronous and asynchronous learning, weekly interactive lectures, discussion forum and LMS, mentorship, experiential learning, case discussion, quizzes, and they were also asked to present. They'll prepare on their own. And the next one, this we have conceptualized in our own institute by our medical education department. So it's called a SPLICE modules. SPLICE is nothing but the self-directed, problem-oriented, lifelong learning using integrated clinical case exercises. So what we used to do is we used to prepare the modules on we have identified the clinical conditions of the disorders once the medical graduates start practicing in our own area. So we have identified around 20 to 25 clinical disorders like nutrition anemia, COPD, bronchial asthma, and all those things. And we have prepared the modules. And this is not related to the curriculum. These modules will be given to them, and they will be divided into 15 groups, 10 in each group. And it's all the activities have to happen, and the learning has to happen outside the campus. Only thing is they will have the groups, WhatsApp groups or whatever it is. The faculty will be there as a facilitator, not to give the inputs with related to the subject. It is with related to how to facilitate the groups, right? And the learning will happen in small groups. Early clinical exposure was introduced. The SDL, it's a pure SDL and based on the adult learning principles. And finally, all the 15 groups, they will come. We will have the plenary sessions. One day it will mark it for that, and they will come and present all the modules. And instant feedback will be given by the faculty. And this is one of the module with related to bronchial asthma. Then this is about the CAT, coronary artery disease, then emphysema, then hemolytic anemia, and the nutritional anemia. This is with related to the systemic hypertension. So we believe that by virtue of all these things, introduction of these innovations, we are positive that we are able to inculcate into the students with regard to the future skills like cognitive flexibility, critical thinking skills, and the lateral thinking skills, emotional intelligence, social intelligence, and the creativity. And what are the outcomes? We need to have an evidence. At least I will not say that it's 100% works, because it is still in the evaluation process, and we are evaluating the course. And if you look at all these things, for example, these are the two first-year students, Sanjeev Vinod and Sarika Sri. They have won in the decoding COVID-19 quiz competition at the national level. And these are all the people who have, we the faculty, or from the research or the ethics components or the ethics teams, we have never went and called them for preparing for all these posters or the presentations. It's all done by them. They were not at all involved in the picture, right? And also this has happened during the COVID time. So if you look at it, the topics, what is next for COVID-19, impacts, lessons, and future. The practice of the solidarity during the COVID-19 pandemic. This is the one which has, they won the first prize in the hackathon. And I'm glad that the first year medical students are talking about not only knowing about the solidarity, but they are also able to present about the solidarity. That is very, very important, because it's away from the science. It is away from the science. Then other group of children, they have spoken about the adverse effect of the coronavirus pandemic on the LGBTQ community, then impact of COVID-19 on mental health and well-being. And most importantly, the first year students, they could be able to write their own paper without any help of any of the faculty. And they are able to publish the scoping review on the reported evidence and gaps on the risk of diabetes in dyslipidemic patients under the statin therapy. Starting from the conceptualization, starting from the formulation of the research question, it has been done by them. Only thing is, myself and Dr. Joshi have helped them with regard to how to submit and how to facilitate the publication process. And I'm very glad, and I congratulate these two children that they are able to publish a paper in their first year of the first profession of the medical school. And they didn't stop with that. You could see bioethics, professionalism, and personal well-being and undergraduate medical curriculum, a futuristic approach. This is purely a reflection of what they have learned. It's also been under the review. COVID-19 vaccine hesitancy among the LGBTQ and factors fostering its refusal, a scoping review, and students' perspective on encompassing research in undergraduate medical education. Again, it's a reflective writing. It's also been in the review. Digital health interventions and well-being of university students in India, a scoping review. A scoping review of literature on use of mobile health interventions on the breast cancer. All of them are under review. We are awaiting for the reviewers' comments. And with all these things, I have confidence that we will be able to accomplish the goals of the components of the SDG 4 by ensuring inclusive and equitable quality education and promoting lifelong learning opportunities for all. Here, I wanted to make one important point that we never discriminate medical student or nursing student or allied health science student. All of them are the HPE, and whatever we are giving the value added courses to the medical students, and we are also giving to the nursing, and we are also giving to the allied health sciences students also, because they all have to work in teams in a constructive manner. Then only the quality health outcomes will be achieved. And these are all the references my session. And I sincerely thanks Dr. Russell D'Souza and his team, and Professor Dr. Ved Prakash Mishra and the SRMC and the SRMC team, and all the other people, and the dean, my dean, Dr. Ilam Bharati sir, and my medical superintendent, along with my sincere thanks to Dr. Sri Shakti Kumar, who has believed in me and who has appointed me as the AMEE India lead for the Panimlar Medical College Hospital Research Institute. Thank you very much.
Thank you, Krishna Mohan, for very informative and meaningful deliberation on the important topic, beyond campus training, professionalism, and lifelong learning skills, which are one of the important roles of the IMG and which require training in other than core curriculum hours. We do agree with it. So thank you so much. Over to Mary Madam for your inputs.
Thank you, Dr. Sunita, and thank you, Dr. Krishna Mohan. It's really lovely and wonderful to listen to what you have presented. This is an example of the vision and mission that a medical college can have, how it can impact future medical students and doctors. and what we produce depends on what is put in our students. You told us, described very well about professionalism, how to teach, how to assess. I have a few questions. If I may take some questions before we open it out to the audience. Dr. Krishnamohan, do you
Yes, ma'am.
think our young students, we mold them young? Remember, our Indian students start medical college at the age of 18. And they are comparatively very young when you compare the Western, medical students.
Yes.
So they learn a lot through role modeling. Do you think, my first question is, do you think we have sufficient role models for them, to emulate? And the second is, we assess all these skills such as professionalism and lifelong, especially professionalism up to when they are medical students. Do we assess them when you actually see the fruit of your training, that is internship?
Yes, ma'am. To your first question, ma'am. Yes, ma'am, compared to the Western medical schooling system, our children are very young, and definitely we have the role models, ma'am, but how well we conceptualize the role modeling is very, very important. And also we have to give sufficient chance and the space for the children to utilize the concept of the role modeling. I feel that that's where missing. Each and every teacher is unique in their own way, but ultimately whether we are allowing the students to get along with the role modeling concept or not is the question. I think with the CBME, the rolling out of the CBME and the implementation of the CBME, definitely the role modeling can play a key role.
What about our training, assessing professionalism during internship? Because that is where we see the fruits of our teaching and learning.
Maybe by the time, because with the incorporation of the AET-COM and also the competencies that have been incorporated into the CBME, by the time we approach the internship, I think definitely we will be able to assess the professionalism in the graduates who have who have been trained with the CBME.
But are we assessing during internship?
As of now, I don't say completely yes, but it is no. But by the time the CBME children will enter into the internship, definitely we will be able to see that component of assessment of the professionalism during the internship.
Thank you, Dr. Krishnamohan, because what your institution is doing is beyond medical training. You're teaching them to be lifelong learners, to be professional throughout their career. And I think yours is a true example, of making a holistic doctor out of your students. And thank you very much. I'll open the floor for discussion if there are any questions.
No, I have only one observation to make. Dr. Mary has raised a very pertinent issue. When we are talking of the period of internship per se is a period of hands-on training under supervision. And as a matter of fact, the total competencies which have been crystallized in the entire MBBS curriculum across the 4 phases, it is the hands-on orientation thereof, because satisfactory completion of internship is expected to be resulting in conferment of a degree, and that is going to result in registration of the learner as a registered medical practitioner. So therefore, the competencies which are expected to be dispensed on his own are getting certified through the satisfactory completion of internship. Therefore, Dr. Avinash and the people will agree with me that when we are crystallizing the evaluation of the internship program, professionalism as a core has to be identified for the purposes of hands-on supervision and certification as well. As yet, we have not worked out an objective mode of assessment of internship as a whole in terms of its appropriate structuring. It is even now just monthly completion, posting, certification without any end examination also. So to that extent, we still feel, and there is a reasonable scope for all of us to structure the evaluation of internship, where professionalism as a whole should be incorporated as an integral component for hands-on supervision, assessment. Then only we will be in a position to say that we have readied the entire intern upon the satisfactory completion of the internship with all the 5 desirable attributes of being a good clinician, being a good professional, being a leader of the health team, a good communicator, and a lifelong learner. I think these 5 attributes must be segregated in terms of the assessment model also of critical appraisal of internship, and that should mean the end certification of the internship rather than the present mode that we are putting into operation.
Thank you, sir. This is open for the House. Yes.
It's very nice to see you. We all are very.
Yes, sir.
You, Sarita, Shiva. So it's very nice to see you. I have one question to ask you. Like, how do you squeeze time for all these, other than the parents of display, anatomy, physiology, biochemistry, we already are short in time. How do you squeeze time for all such activities? I mean, just knowing that.
It's how we planned was every Monday, 6 to 7, they'll have the ethics session. And also Thursdays, every Thursday, 6 to 7, they'll be having the research class. Initially, when we said that there is a beyond campus training, then children also felt that they have that threatening environment. But we only went and explained, and most importantly, when Dr. Joshi has traveled and when Sir and all have traveled, and when they spoke, they already convinced that they have so much of leisure time. I think for us, 8 to 4 is the class timings.
Yes, yeah.
After that, 4 o'clock, they will leave. So we only asked them, you spare 1 hour or 2 hours per week in your spare time, so that this will be useful in a meaningful manner. So I think it has clicked it. And once the children started listening to all these people, as Dr. Mary has asked, role modeling, it started. So yesterday also I was telling, duty of candor, I thought that they will not be able to understand the concept and they will not be able to ask any session, and this will be a very short session. But it went until 7:45, and Professor has to leave because for them he has to go to the college, and he was going on requesting, and children are also requesting 2 more questions, something like that. So I think we have to bring out what are all the competencies.
All of us know that all these qualities like professionalism or altruism or empathy are innately unmeasurable because it belongs to the domain of affect. Like, in what way are you assessing? Are you assessing in a state-wise manner, or you are straightway assessing them during internship, or are you assessing at the end of every professional?
No, actually, what we are doing for this beyond campus training is, Sir has put up a very structured evaluation process about the course. Both the courses, research course as well as the ethics course, they are doing the thing. And also, most importantly, we have started the serial compassion and empathy study. At the first year, we are giving the questionnaire, the instrument, and then we are assessing the compassion and empathy. And then serially, every 6 months, we wanted to assess them over a period of 5 years.
That's pretty much for the dramatic realization. We want to see whether there's a drop. The dramatic idealization. So with this fact, where we are starting at the age of 18, person from the community school, where actually having this values, moral values, and personal values. Yesterday, we brought this in actually. This component was brought by Professor Ronald Hart when I was in 90. So recently, he did say that we teach many competencies, but one of the important things for doctors is depression and suicide. Yesterday, it is 11% of the post-COVID, 12%, much higher than the population, and yet they do not have any idea of that. So we have introduced a whole set of compassion, fatigue, demoralization, of embitterment, all these areas. So even by the time they finish, they will have a good understanding of this. So that's the personal well-being. But overall, Professor Gerard Fortwinkel from Hanover is part of this, and he's there for the evaluation scheme that's happening every 6 months or so, and we also have these 2 studies going on for the next 5 years. So that's looking at that. And I think this question of time is very good what they've done outside campus. Outside campus cleaning. And I was also a bit wondering, but we've seen 90%, and Dr. Wett he takes one of them. I think he takes the class on moral values. Why do we need moral values, right? And
thank you, sir. I'm just interrupting in between. Dr. Judy, she has joined us. She is the Director of International Collaborations from AMEE. So good morning, Judy. We all can see you. Can you hear us?
Yes, I can. Thank you. Hello.
Good morning, Judy. How are you?
I am very well, thank you.
Judy, can you see us?
Yes, I can see Tripti's head.
and I am able to see a headstrong lady as well.
Can you see me now?
Yes, I can.
So, Judy, we are in this. We are on the second part of the CME. So, Dr. Krishna Mohan just spoke about the beyond campus training, professionalism, and lifelong learning skills. So, we are having an interactive discussion just to bring you on track.
Yes, I've been listening in the background. Thank you. It's a very innovative program. I'm really interested in that. It's very exciting.
Thank you. Thank you.
Sir,
Can I just say a word?
Question I shall.
Judy, I don't know if you can see me. You can't see me, can you? Russell D'Souza, yeah.
Yes, I can see you.
Good. I want to welcome you. Dr. Judy has come in. We've been planning this program since 2019, but she's coming and she's coming to really good. And I'm really looking forward to Judy taking this whole program well into the end. Welcome, Judy, and thank you so much. I know it's early morning for you, getting in here, and I appreciate that. Thank you very much, and look forward to your joining us in all the remaining program here today.
Thank you very much. Thank you.
so with the permission of the chair, can I speak now?
So this is the last question because we are running short of time
Thank
and
you.
2 more sessions to go.
Thank you, ma'am. And first of all, let me congratulate you, Dr. Krishna Mohan. So wonderful. I think you have presented the innovations, especially the moral and ethical values, the tools, apart from that, how to assess. And really, I think commendable and can be emulated, I think, across the universities. And I would also like to, to this audience, that yes, like the CBME module has been really implemented to the letter by the DMIMS University also, as you really know, and especially the EdCom module initiatives, which have been in the first professional, second professional, and third professional year. As you rightly said, professionalism and communication. The communication is one of the skills, which is the key, I think. And that has been really nicely implemented here, especially related to the level 1, level 2, and level 3. These are the 3 levels here implemented. And Dr. Vagasar, who has been, taking the initiatives there quite, way back before the CBME.
Yes.
Yes. And so the level 1, sir, is about success and credibility, wherein we have trust and competence. Then the level 2 is about, the communication, the conversations, the discourse, the debates. And the level 3 is basically about the written communications, the common errors we can have in writing, then about presentation skills. Apart from that, we have quite a lot of value-added courses built in, and these value-added courses some of them are mandatory for the first professional, the second professional, and third professional. So basically, these are to sensitize the undergraduates actually for cross-cutting themes related to SDGs, and especially develop some creative and divergent competencies in the professional, the undergraduates. And these, it's very innovative, get, set, go That's the title which has been given to the mandatory skills. These are the skills related to, team building, leadership, presentation skill, even the soft skills, resume writing.
Yeah.
So that, the employability,
Exactly.
that also we have to teach.
Yes.
Apart from that, the postgraduates also have these mandatory soft skills, talking about
Madam,
research and systematic reviews as well. So just madam, we would like to talk about
Thank
our
you so much.
Thank you.
for sharing
you.
the initiatives undertaken at DMINS. Over to MOCs to conclude the session. Thank you so much.
Thank you, Dr. S. Krishna Mohan, for letting us have the privilege of having this interactive session with you. Thank you, Dr. Mary Matthew and Dr. Sunita Wagh for chairing the session.
Thank
I
you.
would like to invite Dr. Sunita Wagh to felicitate our lead faculty, Dr. Krishna Mohan, with memento as a token of love and appreciation.
I have already addressed. I would like to invite Dr. Ilambarthi sir, our dean, and Sabaratnavel sir, our medical superintendent, who has joined virtually. And I think sir is chairing the next session. Our dean sir is chairing the next session. Sir, I wanted to thank you for giving me this opportunity, and I want to say a few words addressing the gathering here, sir.
Good morning to everyone. Dr. Krishna Mohan is the professor of biochemistry and the vice principal. He is very much involved in our institute academic activities. We are very happy to have him here as vice principal of our college. Thank you, one and all.
Thank you.
Thank you, sir. Thank you very much.
Dr. Mary Matthew will be felicitated virtually. I request Dr. Suvarna Sande, Professor and Head, Department of Microbiology, to felicitate Dr. Sunita Wagh. Thank you, madam.
Moving to the next session on ensuring quality by training in altruism, ethics, and humanities, would like to invite Dr. Ilam C., Dean of Panimalar Medical College Hospital and Research Institute, Chennai. He will be joining us. He is joining us on virtual platform. And Dr. Adarshilata Singh, Director of School of Health Profession Education and Research, DMIMSDU, Savangi Vardha. I would like to invite both the chairpersons to chair this session. Over to you, ma'am.
Thank you, ma'am. Swami Dayanand Saraswati viewed the education as formulators of character. With this note, I welcome all the dignitaries and eminent faculties to this CME. First, I want to thanks to the organizing committee for giving me this golden opportunity to chair this session. As since morning, we are talking about CBME or competency-based medical education. In the competency, if we go through the IMG, the competency, core competency, which we all want at the end of the curriculum, that our learner should play safe, competent, and patient-centered care. If we want this, which are directly related to ethics, humanities, and altruism. So in this session, our speaker, Dr. Gaurav Mishra, who is Dean Faculty of Interdisciplinary Sciences, 2 PhD holders, many specialty fellowship as in curriculum design, program evaluation, also in fellowship in intervention radiology, bioethics. At present, many research publications on his name. At present, he is also holding the post of editor-in-chief of the AMS JNMC journal. He is going to speak on ensuring the quality by training in altruism, ethics, and professionalism. So over to Dr. Gaurav.
I thank you, ma'am, for calling me here. So to start with, a very, very good morning to all the honorable and respected esteemed guests of honor, respected lead faculties from various representative institutions for AMEE networking centers, respected chairpersons, respected faculty, teachers, students, and my dear friends. To start with, the title is Ensuring Quality Through Medical Education Through Ethics, Humanities, and Altruism. Now, to start with, these 3 words, ethics as well as humanities and altruism. When we go into the detail of the ADCOM module, as Dr. Kirtana ma'am and Dr. Krishna Mohan sir have already pointed out that there are 54 competencies, you will find that these 3 values are ingrained in those 54 competencies, irrespective of whether there are core competencies or non-core competencies. So before delving into deeper of these aspects, I would like to highlight that in the first 2 presentations, we have been more on the practical side of things, on the practical side of assessment. We have been through the Miller's pyramid of clinical competence. We have been through the various levels of it. We have been through the various requirements as well as virtues, qualities required for being a professional, which is one of the goals of the IMG, that is Indian Medical Graduate. So myself, Dr. Gaurav Mishra, I am serving in the Department of Radiodiagnosis, Jawaharlal Nehru Medical College, Savangi Meke Wardha, which is a constituent unit of Datta Meke Institute of Medical Sciences, deemed to be university. Now coming back to the 3 aspects, ethics, humanities, and altruism. So to start with, I would like to say or mention that this talk is an opportunity given to me, for which I am really thankful, to delve into something which is really necessary, more and more pronounced, but less and less read. We can say that it is much more judged in these nowadays times, and less taught, and less, unless and until it finds its basics in the teaching and learning curriculum in the medical education, which it has found itself. Yes, we are talking about ethics, medical ethics. We are talking about altruism, and we are talking about medical humanities. So these three form a part of the present AdCom module, which is basically a set of 54 competencies, including the core and non-core competencies. Now, coming to medical ethics, to begin with, let us just begin with these 4 basic or main principles of bioethics. These principles have been partially told by Dr. Krishna sir in his presentation with reference to professionalism. So the first principle of respect for autonomy. Secondly, the principle of non-maleficence. Thirdly, the principle of beneficence. Fourthly, the principle of justice. It is important to highlight these 4 basic main principles of bioethics, because whatever our curriculum is going to revolve around, whatever the competencies regarding ethics, attitude, and communication in the AdCom module are going to revolve around, are these 4 main basic principles. These are a set of core principles which we can say that they guide a two-way interaction in between either 2 human beings, or a living thing or a non-living thing. What I suggest to put forth here is a metaphor. No, metaphor is just like a figure of speech, it's an implicit comparison of things. Now, what I try to put forth here is bioethics, or medical ethics to be very specific, is something which is like a cement. Just like the cement holds together the various building components, the bricks, and all that is required to make up a building and erect it. It acts as that. So that metaphorical, implicit or explicit comparison can be made here. In this two-way communication in between the human beings, with use of ethics, with use of altruism, and with use of medical humanities, the most noble and anticipated as well as ideal outcomes are to be drawn out from both the sides. So mote it be, as they say. These 4 principles, they had come from a seminal work, which was a part given by 2 great minds. One was a theologian, who was James Franklin Childress, and one was a philosopher, who was Tom Beauchamp. So these came just sometime before the 1978 Belmont report they had released by the United States Department of Health, Education and Welfare. Now, coming to the term bioethics. This term bioethics was given by another American biochemist known as Van Rensselaer Potter. It was in 1970, means even 8 years before the Belmont report had come into existence. People have been thinking about this bioethics terminology. As to shine some light upon the various 4 principles, we all must delve into what basics of these 4 main principles mean. Autonomy sets, that is the first principle, autonomy sets the rights of an individual to self-determination, determining by oneself with an implicit or explicit sense of respect and upholding the ability to make informed decisions. Now, this can be attributed to various situations in which the patients come to us in a disease state. In case there is a disease which needs surgical or radiological intervention, it is up to the patient to choose whether he wants or she wants to undergo that intervention for himself or not. We cannot force it upon him. Secondly, beneficence. Beneficence refers to all those possible actions which can relate to the fact that you have to promote the good, you have to promote the welfare of others, welfare of the patients, welfare of their families, welfare of their relatives. Do good. That is beneficence. Thirdly, non-maleficence. It is I would say that it is a synonym or an antonym, but it means the same, because the second principle says do good and the third principle says do no harm. So non-maleficence comes from the Latin sentence or a phrase, I would say, primum non nocere. So this is something which gives rise to non-maleficence, and non-maleficence, I'd say that it finds a place in the Hippocratic Oath as well. Finally, justice. Justice refers to the most relevant and appropriate distribution or allocation of health resources. When we talk about justice, for example, we recently had a COVID pandemic and there was a shortage of COVID-19 vaccines all over. In a country like India, where there is such a high population, we faced many challenges while allocating these vaccines to the various groups of population in India. But then here is where the bioethical principle of justice comes in. As Aristotle said, giving to each which is his due. According to Beauchamp and Childress, once again I'm quoting them, they stated in 1994 in their work on page number 330, they gave us 6 points for the bioethical principle of justice. First, to each person, an equal share. Secondly, to each person according to need. Thirdly, to each person according to effort. Fourthly, to each person according to contribution. Fifth, to each person according to merit. And sixthly, to each person according to free market exchanges. See, I am delving deeper slightly into the literature aspect of things because it is necessary to go in these aspects as well, because these are what are going to form the foundations of what we are going to do in our assessments, how we are going to design our strategies for various professionalism assessments or assessments of various competencies which are in relation to ethics, communication, and attitude. Coming back to literature, the Roman Stoic philosopher Lucius Seneca, he once wrote that people must be taught to give benefits freely, receive them freely, and return them freely, and to set themselves a grand challenge, not just to match in actions and attitudes those whom we are obligated, but even to outdo them, for the person who should return a favor never catches up unless he gets ahead. There is a statement which is a converse of it, and it also reflects in the literature that anyone who thinks about being repaid, he is giving and deserves to be cheated. Coming to medical humanities and altruism. Now we shift from bioethics, which I would like to place another metaphor, that when in school or any time in our life, we are supposed to learn a new language and learn the intricacies of it, the various phrases, idioms, how to speak, how to behave. We refer to something which is called as the dictionary to find out the meanings of various words. So I would like to place the same metaphor or implicit comparison for ethics, altruism, and medical humanities as far as the attitude, ethics, and communication module of CBME is concerned. Dawkins states that altruism, if viewed on a universal scale with a filter of rationality, yes, it is just another name for super niceness, human super niceness, I would say. According to Mises, it is going to hold true for any and all human beings in this world that altruism only would logically exist in a world where there is deficit, shortage, or scarcity. I would like to again state that it might sound slightly altered here, but energy always flows from somewhere. It is a positive charge to a negative charge. So the same thing is about the human society as well. Imagine if we were to live in a utopian world where we would have a world of superabundance. Every person had everything. They did not need anything from anyone. So there would not be any scarcity or deficit or shortage felt by anybody. But that is not the picture. There would be no need for any person to give or take or make a trade or something like that. However, when it comes to the human expectations, the human behavior, the facts and the virtues of human behavior, the goals of the IMG, professionalism in particular, it is not like this. There are some loopholes, there are some negative points here where they need to be taught. The students need to be taught. Like, for example, the patient comes to us in a state of deficit. The patient would not come to us in a state of abundance. Just like he comes to us in a disease state and he seeks treatment from us. So that is a state of deficit. So how the doctor or how the medical graduate or how the IMG or how the medical student behaves with him in various aspects, in various filters, this defines their future relationship, the doctor-patient relationship, I would say. To be clear, again, I would like to say that Michael Tomasello, he tried to define altruism. He gave 3 categories of altruism. First, he wrote, to be altruistic with respect to goods such as food is generous and sharing. Secondly, to be altruistic with respect and with respect to services rather, it is to be helpful. And thirdly, to be altruistic with respect to information is to be informative. David Wilson also defined altruism, but in a more logical and comprehensive manner. He defined it as intentional action ultimately for the welfare of others that entails at least the possibility of either no benefit or no loss to the individual arising, where group level functional organization evolves primarily by natural selection between the groups. What we wish to contemplate and make up for ourselves out of these great virtues of medical ethics, humanities, and altruism lies very well within the domains of these literatures. Now coming to quality assessment with relation to these 3 virtues. We all have seen the Miller's pyramid of clinical competence. Now some pieces of literature say that there are 5 levels of Miller's pyramid. Some say that there are 4 levels, but we will consider that we have a 4-tier system. The level 1 is knows, second is knows how, third is shows how, and finally we have the topmost level as does. So this is in the order of increasing and refining clinical competence. Now what we are trying to suggest here is this pyramid or Miller's pyramid of clinical competence can be used for calibration of competencies. We have a set of competencies which are derived from a subject. So here we are talking about ethics, altruism, as well as medical humanities. Now we already have a set of 54 competencies in the ATCOM module, which has been given to us by the apex regulatory body, that is National Medical Commission of India. Now, they have also given a method or a scale to suggest the mode of assessment for this, specifically communication. That is given, I think, on the last page of ATCOM module, that is Kalamazoo census. And it is a very useful method, I'd say. Now here, I would like to just superimpose the various domains, learning domains, along with the Miller's pyramid of clinical competence. The cognitive domain will be including the lowest 2 levels, that is knows and knows how. Then the psychomotor domain will be also considering the shows how as well as does. And affective domain, it only comes when we are talking about the topmost level where the graduate or the doctor does that procedure independently. One suggestion is this system can be used to calibrate competencies according to the learning domains. Now, when we come to assessment, when we come to quality assessment of these competencies, we have multiple modes of assessment which have been suggested to us by again NMC. But I would say that these are not the only ones which may be used for assessment, and there may be more such assessment methods, and it needs further research, which we are looking forward to. For the cognitive domain, where we are talking about the know and know-how levels, We can always assess them in theoretical papers as a part of theory. And we can always take viva of the student where he can answer us that yes, he knows, and he knows how the particular procedure is done. So the various modes of assessments for a cognitive domain competency involving the know and know-how level, they might be MCQs, that is multiple choice questions, short answer questions, brief answer questions, long answer questions. And this encompasses over the theoretical aspect of the subject. Coming to the practical aspect, we have case-based discussions and case presentations, as well as portfolios. So these there is a superimposition, or there is a correlation in between both these theory and practical modes of assessment, because the database or the base of subject lies here in between both. It is a common set for both. So the student has to have the reading of the subject textbook, as well as he has to have how the disease or the particular intervention is required in which kind of a disease or which kind of a patient. Coming to psychomotor domain, it shows how, as well as the shows how and does level of the Miller's pyramid. So here we are completely talking about the practical aspect and affective domain aspect of the competencies. We have objectively structured clinical exercises, objectively structured practical exercises, mini CEX, that is mini clinical evaluation exercises. Then again, as we progress further to the higher level of DOES, we can have a 360-degree feedback. For example, I am a doctor and I am performing a procedure on a patient. There will be multiple peers around me. Even the patient will observe me. His or her family will observe me. So how I am communicating, how I am carrying out everything, this will be assessed by every one of them. So this is something which is called as multi-source feedback or 360-degree feedback. Talking about educating the same to students and assessing them. So as Dr. Krishnamohan sir already stated that we have 27 modules, 54 competencies in the ADCOM module as such. They have been distributed into 4 phases, 5 modules for year 1, 9 modules for year 2, 5 modules for year 3, and again 8 modules for year 4. So these modules can be taken as a reference, and using these modules as a reference, more modules, more scenarios, more case-based situations can be produced where different aspects of human communication in between doctors and patients, or in between doctors and doctors, in between 2 relatives, or in between patients and patients, they can be considered and given a follow-through. So this is basically case-based scenarios. So I would like to say that a combination of calibration of the curriculum for ADCOM module, which is given to us by NMC, along with aptly and relevantly incorporating the modes of assessment which have been given to us, but they are not limited to only those. Educational research in this direction will always reveal and will always disclose that there are more and more methods of assessment. Finally, to deliver a concluding note to the perspective of ensuring quality in medical education through these 3 virtues, I would like to again quote something which was from 2012 stated by Wilson. Beyond the ordinary instincts of altruism, there is something more delicate and ephemeral in character, but when experienced, it is transformative, and that is honor. A feeling which is born out of innate empathy and cooperation. It is the final reserve of altruism. With this, I conclude my talk here, and with the last statement, as I said, that all the methods of assessment which have been given to us by the apex regulatory body, they are not limited to only those, and educational research will prove and give to us more and more methods of assessment as we delve into the 3 virtues deeper. Thank you.
Thank you, Dr. Gaurav. Dr. Ilampurti, you want to say something?
Yeah. First, I thank the organizing committee for giving me the opportunity to start this session on ensuring the quality by training in altruism, ethics, and humanity. I congratulate Dr. Gaurav Mishra for his fantastic and extensive talk on altruism, ethics, and humanity. Now, by furnishing the training in altruism, ethics, and humanities in health profession education, it is possible to enhance the quality of medical care provided by the healthcare workers. Altruism, ethics, and humanities are important professionalism attribute for health professions. But due to existence of wide variation in understanding and establishing them in medical practice, it is existing as a complex subject. These gaps can be addressed by providing training in altruism, ethics, and humanities at the conceptual and practical level in medical education and medical practice. At the conceptual level, revision in curriculum with the more emphasis on empathy towards patients, better communication skills, better teamwork, and the practice which are feasible should be focused. At the practical level, students may be taught the essential altruistic behavior in a more practical and meaningful manner by developing case-based scenarios in preclinical years and a workplace-based technique in the clinical years. Overall, by imparting training in altruism, ethics, and humanities in healthcare professional education, it is possible to deliver quality education and quality healthcare.
Yes.
So now I open the floor for discussion.
Yes. Please introduce yourself.
A very good afternoon to all the dignitaries on and off the dais, and heartiest congratulations, Dr. Gaurav, for a very insightful talk, and virtually you have touched all the aspects of ethics, humanities, and altruism. So in addition to this, I would just like to add few of the initiatives which we have also taken at the Tamega Institute of Medical Sciences deemed to be university, wherein we have tailor-made all the modules for all the professional years in terms of mapping all the teaching learning methods and the assessment methods. And we have copyrighted all the modules from professional year 1, 2, 3, and 4. And we have also come up with a textbook, which is a manual for the faculties and students, wherein the teaching learning and the assessment modality for each module is invariably given. And one of the major aspects, which was a major challenge, that is the assessment of all the competencies at 8Com, have been addressed, and we have linked that particular assessment modalities with the logbook, and we are doing the assessment in form of continuous internal assessments. So that is one thing. And Dr. Gaurav has done his PhD, wherein he has also added few of the modules of bioethics, which he would also elaborate much. And I would also like to just have insight of you all in terms of assessment, particularly of all these competencies, which is a major challenge which we face. So that is what I would just like to know.
Since we are running short of time,
Thank you, Dr. Shweta.
I request that we won't be taking any further questions. Any discussions which need to be done can be done during lunchtime, one-to-one basis. So over to Dr. Adarsh Lata Singh.
Thank you. Thank you to all, and thank you, Dr. Gaurav. We
Thank you, ma'am.
conclude the
Thank you,
session here.
everyone.
Thank you.
Thank you, Dr. Gaurav Mishra, stalwart of medical education, for the lucid and the elaborative talk on this topic. Thank you, Dr. Ilam Paruthi C. and Dr. Adarsh Lata Singh for incorporating their inputs and chairing the session. Thank you, ma'am. We are honored to invite our chairperson, Dr. Adarsh Lata Singh, to felicitate our lead faculty, Dr. Gaurav Mishra, with the memento as a token of love and appreciation. We are fortunate to have Dr. Ilam Parvati C with us. Dr. Ilam Parvati C will be felicitated virtually. I request Associate Professor, Microbiology Department, Dr. Sarita Ogemuge ma'am, to felicitate our chairperson, Dr. Adarsh Singh. Thank you, ma'am.
Let's proceed to the fourth session by Dr. Dinesh Padyal, who will deliver a session on topic role and relevance of faculty development for quality medical education. I would like to invite Dr. Abhay Gaidhane, Dean Jawaharlal Nehru Medical College, DMI MSDU, and Professor Community Medicine, along with Dr. Swanand Pathak, Professor and Head, Department of Pharmacology, JNMC, and Member Secretary of Institutional Ethics Committee, DMI MSDU. I invite both the chairpersons to chair this session. Over to you, sir.
Very good afternoon to all. For the next session, I would like to welcome Dr. Dinesh Padyal. He will be speaking on role and relevance of faculty development for quality medical education. Dr. Dinesh is a Vice Principal of Medical Education and Professor in Department of Education and Pharmacology. He is also convener of NMC Nodal Center for Faculty Development and Director CMCL FEMA Regional Institute. Dr. Dinesh is also a national convener for NMC Advanced Course in Medical Education, and he is also an NMC Task Force implementation of the competency-based UG curriculum in India. Dr. Dinesh is currently affiliated to Christian Medical College, Ludhiana, and he has many achievements to his credits and honors and many publications. So over to you, Dr. Dinesh, for your session.
Thank you, sir. Thank you, chairpersons, all the dignitaries, on-site and online, all the colleagues and friends. This state we're going to deliberations because we are quite late into that. So when they told me about that, mainly today we are talking about SDG 4 and how we are thinking about quality in faculty development. So as you know, first let me introduce that as one of the AMEE centers we have under CMC. We are 128 years this year for establishment with 5 constituent colleges and the NMC Nodal Center and the CMC FEMA Regional Institute. So all that experience we had with the faculty development and under guidance of our mentors who are sitting there, Dr. Ved Prakash, Dr. Vinash, all the faculty development which we have learned and then implemented. So we'll sharing some of that. You might be knowing that there are many stakeholders when we talk of medical educations. And when we look at education SDP G4, so education for sustainable development, availability of skilled workforce under that, capacity development, job creation, employment, that is also part of that. And if we look at the quality, which we are trying to associate now with the faculty development, people are asking with these questions. You have implemented, what has happened, people have been trained, so many thousands. But what is the impact of that? So it's like a beauty, it has a positive connotation, but it's nothing measurable, which we have been struggling for most of the time. For quality to be managed, it must be defined in terms of specific measurable attributes, which is being asked now everywhere. So evidence, where is that evidence? Now we look at right now the standards which are available. One is continuing professional development under WFME. So this says that all activities that a doctor undertake formally, informally, in order to maintain, update, develop, and enhance their knowledge skills. So there are set of standards under that. And if we look at basic and standard, I'm picking up the quality from here because we are talking about that only. So medical profession should ensure that and this mission encourages and supports doctor to improve their practice performance, addresses the obligation to improve the conditions for effective continuous professional development. Let's use a term today which we are mostly using in India, faculty development. So FDPs are faculty development programs. So as we know, for the new curriculum and other needs also, they are required to prepare and train the faculty for their multiple roles. In India, we have multiple roles. We still don't have you can say, subspecialties in the faculty development. So present emphasis is also the new curriculum, which is there. So everyone is getting trained. So now you have a third batch, fourth batch is coming. Students are asking teachers the new terms. And some of the teachers are coming back to us. Earlier, who were not so interested in faculty development, they want to know because there is a demand from the major or the end use customers or the stakeholders, the students. So it should be considered more of a necessity than a luxury. Okay, that has changed now. So as this serves as a major quality assurance factor for colleges and universities. You have NIRF now, rankings and other components coming into that. So putting up all these things together, you people have all experienced that. Okay, the FAMER courses, ACME courses, ATCOM. Now, if you look at this pendulum which started, the curriculum changes which has happened, we have faculty development at each level. Okay. In fact, the people who have developed these courses, they were all trained in these components. So all the people, more than 100 who were involved in all these components, as Sir has taken that initiative that people trained in educational methodology, curriculum development, they should be a part of developing these components and these documents. So when this was happening, national conferences, CME, workshop, we saw many of them on the CBME. I think today also there might be some workshops or programs happening on the CBME in India. So every day is the program or a faculty development program happening. Now, if you look at some of you who have seen the curricular governance, you will see quality assurance and improvement is already built up into that, which should be independent of your medical education unit or Department of Medical Education. They are implementing it. So you should have another control unit under your dean or the principal, which looks at this component. So that is a part already which is given. People ask us, but we say, okay, these are the faculty development caterings, which right now you have. Okay, whether you talk of short-term courses, 2 to 3 days, CIS or vice basic course or long-term courses, which are there. So when we look at these courses, apart from that, people should also do lot of other workshops, 2 hours, 3 hours, afternoon workshop. People are busy, clinicians. We should not, AMEE should not stop doing only the regulations, the NMC courses, but non-NMC courses also, which are needed in all. For example, simply I know a lot of people benefited. We talked in our form, how to design a question paper, how to write a questions. People say there's a lot of that. Impact of that, which has happened to be seen in the university question papers, which is happening. That looks very simple exercise, but the impact is very many. So when we talk about quality improvement, we should look at these some of the outcome measures. For example, question paper quality, which is coming out. CBME, lot of cases have been there. People are talking about, okay, curriculum is CBME, guidelines say that, but the question paper is still in some places not of that. So that is also one of the outcomes when we look at quality. So you need a lot of administrative support for that faculty development. And when you look at already, you know that there's eligibility criteria for those components. That is also one, you can say, one quality step for that. That for going to next faculty development higher, you have something which is already defined at basic level. So this can act as a control, and this is quite well followed. For example, advanced course, even each single candidate is pre-checked before enrolling them, approving the list. So all these components of quality checks are there, which are there. And many of you might have seen that certificates sometimes are not given if you're not attending, or those components has happened that. So making faculty and administrators understand the training in AMEE, which has happened slowly and slowly. Now people sit down through that and they learn there is a need for that. It is not you have to threaten them, okay, you will not get the certificates like you do the students. So we don't have to do that now. Provide incentives and support the busy doctors. As I told you, many institutions has this issue that clinicians are busy. You take them away for 3 days. OPDs have to learn and all that. So alternative arrangement, scheduling, pre-scheduling, and some important topics if you are covering at institution level, maybe after the OPD timings, you can build up into that. So provide facilities, funds, which now every college is providing. This has become a movement. They know it's not only mandatory in nature, which is there, but they know to score good on these rankings, most of which they are going for. One of the criteria is this also, faculty development programs. So when we talk about where we are now today, after 3 years of actual implementation, and maybe we look back 11 years of training, which started in 2009 onward, and where we want to be now, what should be the next step? So looking at that, just giving you quantity and quality both in the faculty development. If you look at the figures which are already available on the NMC website, so if you look at the number of faculties, which Sir told in, Russell also told in the morning, 120,000. Okay, so 1,20,000 around faculties. So 44,000 were trained, and now I am just adding other which has been trained in the last year. The number has crossed 90,000, 90, which are already trained. And I know the robust ways Sir has used, Dr. Mishra, during that planning. We multiply by this and this and this figure. And Sir, exactly that has seen, we have seen that now. So I'm just giving you a few examples of quality assurance. You know about advanced course in medical education. So this has a criteria. For each session, online, on-site, there are marks given. There's a monitoring and evaluation committee for that. So quality control is very strict. It is not you are enrolled, you will get it. You have to go through all the components, all the steps, and then you get it. FAMER has monthly evaluations, email recordings, summaries, lot of other factors are there. And I know a lot of you, I see many FAMER, CMCL FAMER fellows here, and you know all the steps you have gone through that. So that is also there. So all these degrees, when we award them, that becomes a motivation. Okay? There also, it's not everyone is getting that. Only people who are crossing these standards which are set down and very well implemented right now in India at the stage we are. Although full flow where we are looking at measurable outcomes might be take more time. So we are in a sort of quality spiral which you see here. Maybe one cycle we have gone through. The other cycle we will see that academic institution quality assurance processes. Some institutions actually have implemented and they have gone the step beyond the minimum requirement, and they have introduced that this training, not only which is written in the Gazette, other trainings are also mandatory for promotion. So see, NMC says minimum only, but they have done this. So they have implemented that you must do this. This is also to get the further promotions. So that is becoming a part of that, some of the quality checks which are there. So there are many other processes, validation, accreditation of the program which we are running, training of the trainers is happening throughout, peer observation schemes. I know some of the centers are doing at the end of the sessions every day to do this. They have a feedback to each other. Student evaluation of the teaching processes. If you are not involving, please involve some students in each of your faculty development programs. Take their views also at the end of the program. They will give you entirely a different picture. Sometimes we are assuming so much we are talking to each other. We are comfortable in our zone, but suddenly they will shake you up. Okay, so jolt you up. In one of the CME, sir, we asked the students, we told them, this is a new curriculum available there, you read. We trained faculty for many days and then we struggle. They were read everything, integration and all. And we asked them, okay, how you feel? They say, we don't feel anything. This is not new for us because they were new curriculum. They say, for us, this is the curriculum. And we say, what you feel about the faculty? They say, we feel they are very worried. It is an issue for them, not for us. So that is something we need to look into that. And this is the actual real students. So that's what I was thinking about implementation, which has happened with the interruptions of pandemic, more training, more faculty for small group. People are asking, but we have other departments. People are using now residents from other departments. One of our projects in one of the program was using clinical residents for small group teaching in the basic sciences. which is actually a very good thing. And the turn-wise, one resident will get one day, 2-3 hours in one basic sciences. Okay, so that can be done. So I'm taking one example here just for faculty development. If you're training faculty for skills training, you should have a modules for training, infrastructure, debriefing area, technology, appropriate simulation-based learning. You can see on this slide, mannequins are not there. That is one of the items you need, but it is mainly the modules, briefing, debriefing areas, that has more important for the learning. So when we go forward on this, it's not moving. So some of the areas become heavy, like skills training. You need to push it to move. Remember that. So I need help of others. Yeah. So you will find many actually areas like this where you will need a push many times. Yeah. So I was taking this specific example, what a lot of people said we have 1 crore skill lab or 2 crore. And when we go use it, it is locked and nobody has been trained in how to use that. So maybe, so all these things actually you need to that. I'm happy right now, most of the colleges are up to the mark. They're coming up. Now they're started investing in training than the mannequins. So they're trying to understand that. It's a process which happened to that. And you already know that how the curriculum has been rolled out, how much faculty development has happened, okay, especially new curriculum, how many enthusiasm it has generated, which has come. And our experience with some of the short-term program, which we call Revised Basics, CISP and other collaborations, is quite good that even it makes them aware of them. And some of them later on come back to do the other advanced courses. So that is one motivation, but you need to appreciate these people. And even we sometimes talk to their deans and principals to tell them how they are acting or how they are participating in that. And that also becomes point for us to pick up some of those people who we feel are very fit for other advanced courses. So advanced courses, which are 1 or 2 years durations, have really generated a lot of workforce. Now, when we presently see all of the regional centers, whether FAMER or NMC and Nodal centers, and other points of apical teaching in the faculty development, you see most of the people are not trained there. They're well trained in these courses, which are 1 year or 2 year, and they are leading this change, which I think I remember Dr. Inash sir telling us when we entered this field that we are looking at some change agents, which will multiply, and later on this critical mass will be generated. Number were counted. We used to calculate 258 CMCL FAMER fellow. We need 500 to have impact. Now we have 1,000 of that and more than 1,000 of ACME. So that critical mass is making an impact and measurable outcome. Some institutions have done some studies, but we right now don't have those literature. But when we went into all this measurable outcome, we found this changing paradigms, technological advancement and innovations, which is happening and every day in the small group SDL UC people are using, which is making an impact. So continuous quality improvement requires ongoing evaluation and review of effectiveness of all elements of this quality system. Use both the internal and external mechanisms. Sometimes you invite in the RBCs, there are observers, okay, and they are usually there for this purpose only. And we try that observers continuity is there at least for 2 workshops, so they are able to give feedback and also look at the action taken there. So as you know, national standards are there, international standards are there, those guidelines are there. You can use that also. And you can develop actually more. As Sir said, very rightly, we are going to be a force with so many medical education students, and we should be actually devising our own guidelines. In spite of that, we should customize it, and looking at the number of medical colleges, nobody is near to us actually. So we are much ahead of that in the number game. So that should be our strength. Looking at the literature, when we are finding what is the evidence for that, there's small evidence only now, right now, but we have many colleges. We should actually, each of one, you can start this outcome and see what is the impact of that. Whether this quality improvement you are using, observers you are using, all these components, how it is helping the faculty development programs. assessment, for example, this is one area because students when enter, people were not ready with the sample paper blueprinting. That happened later on with the universities. So theory question paper sampling, setting the blueprinting assessment. I am happy many universities have these blueprints and now. Our university also we develop with them. And universities are now inviting trained people. Now they know how to get that also. I know that Dr. Purnia, we talked a lot how university initially was not able to understand. And then they have to make understand, trained people can make these things. So that happened faculty development. And these know how many people have worked there, expert groups under the guidance of Sir, which started. The documents which create, lot of documents which are created. And when we look at the international medical education, boundaries are blurring across the globes. We are talking about international recognitions now. Medical tourism is already inside. Migration, which you have seen during Corona time, and COVID has changed entirely these things. And you have seen that standardizations which help people there. So quality improvement, if you are looking back now at your institutions, think about planning, plan on what you want to do it, then check to see that you put in place is working, monitor and audit. This is very, very important. Right? Most of us have not reached that. Then take corrective actions to right things that are not right. So in that way, you can devise and have a quality improvement. And we talked about this number of times, a model for improving quality educations. Quality improvement, curricular reforms are already happening in the integration. You have so many things happening. Expanded learning opportunities, publication guidelines, a lot of people are producing that. Capacity building in the teachers. Faculty development, some of them have we know some expertise are there in the assessment, some are there in the mini CX and all those. So those are developing now. Financial incentives we have seen now, people are giving them in the institutions at the national level. So that is happening. Research grants and funding, publication. I was happy to see in the ICMR thrust area, medical education is there now. Yes, that is very good. Yes, sir. Yes. So that is one area we can apply. Institutions are giving, as I told you, grants, national ranking, it is happening. So all this is coming together now. So this is a good platform right now for all of us to get together. I'm very thankful to Department of Medical Education, CMC, all the faculty members, our mentors who have, some of them I have seen today online, and some of you are sitting in front of us here. Thanks to all of them for guiding us, making us sure that we reach that stage and we start talking about people evaluating us, the faculty development program which are being done. So thank you to all of you.
Hello. Thank you, Badal sir, for your artistic, but at the same time, I will say to the point, scientific presentation. Sir, it's really a very interesting topic. It is role and relevance of faculty development and quality assurance or quality development. Sir, you very aptly has defined first what's the quality, what are the various levels at which the qualities can be judged, how can we assess that quality. Referring to the faculty development, you referred to many short-term, medium-term, long-term programs which are there in vogue for faculty development. Not only that, sir, you also referred to the recent advancement, that is the CBME, and how can we assure the quality in these changed scenarios. You referred to some hard facts with statistics, like 90,000 of our colleagues are being trained now in medical education technology. Not only that, you referred to the advanced course, quality spirals, as well as peer observers groups and their importance. Sir, the whole topic is such interesting topic that I cannot contain myself from reflecting on it. Coming to the quality indices, there is a concept, sir, that is indicator matrix, a very beautiful concept altogether. If we could put that indicator matrix properly in whatever programs we are running, we will be able to exactly pinpoint what are the short-term, medium-term, and long-term goals. And in my opinion, that what's most important are the long-term goals. Whether the medical facilities in the society, whether the health as a whole in the society is improving or not. It is not just improving the medical education, but ultimately the patient should be benefited with this. Then as compared to faculty development, our approach is quite different, that we first appoint the faculty and then develop it. It is like getting an unfinished good and going home with that unfinished good and finishing it. We don't do like that, sir. Generally, we are content with the finished good that is available in the market. Probably things will be far more better as we will move ahead, that we will have the finished goods in the form of the medical faculties who are already trained, and then we are making them as faculty. Here a concept, as we have a concept of early clinical exposure, can there be a concept of early teaching technology exposure so that the students right in the beginning can have the aim that they want to become a medical teacher, and this is what we want to do as the medical teacher. And finally, the thing that you have referred to, that is involvement of the students. There is one concept, meaningful student involvement. I am thankful to respected Ved Prakash Mishra sir, that is few months back, he introduced me to this concept. Not only introduced, it is his functioning style, that is he made me to write a document on it. And absolutely, sir, because from that I came to know that where the university stands. Now the paradigms are shifting, that they are asking that how much of the meaningful student involvement is there. There is one umbrella phenomena which is there, how you can get everything under the meaningful students involvement, because everything is there for the students. If it is not making sense to them, it hardly carries any meaning. The beautiful example you have quoted regarding the students and how they interacted to one of the programs or the curriculum improvements that you initiated to.
Thank you.
So these were some of my reflections, sir. We are just
I will just say that one point you raised is indicator metrics. In fact, we are working on a whole program evaluation, which will have all the components, because that is needed now. When people are asking how it is effective, CVME effective faculty development.
And evaluation of any and every educational program on the 4-step mechanism, originally for the Dutch model, which we are wanting to look it up for the purposes of program.
And the finished good, you gave an example of a finished goods. So actually, right now, if you look at the MD/MS curriculum, which are in there, and last 2-3 days, revised versions are coming. They should be trained as a teachers. This is already there.
I will just add a small little thing. If you really look at the reorientation of medical education, WHO propounding, there were 3 cardinal objectives which were put across for international medical education across the world. What for medical? Third, which is not come from medical education, medical teaching.
Not to worry, Judy, I'm here. Mary here. I think they've gone offline. You're muted. I'll message them.
Institutional in character, and that is exactly where the onus of the institution ought to lie. It cannot be one-time training. Believe me, 1984 policy, higher education, academic staff colleges came into being in the domain of higher education for what? No promotion and no placement is accruable to a teacher in higher education without minimum 6 months refresher course every 5 years. How successful or how failure it is, I am not commenting. But there is an institutionalization of the academic development program for higher education. Therefore, in a similar lines, institutional level faculty development program, not a one-time, but it is an all-time renewal. A postgraduate teacher cannot be a postgraduate teacher lifetime. He has to be renewing himself in terms of the contributory outcome. If registrations are renewable, why postgraduate teachership should not be renewable? And similarly, why teachership is not expected to be renewable, subject to fulfillment of the required benchmarks which are required to be put up. Therefore, right of a teacher is not only to be assessing students, it is to assess himself for be enabling and enriching him for assessing others.
I will quote sir's one important line. I remember, sir, visibly the last 2 days when we were finalizing the curriculum and it was to go through a website. There were a few things, deliberations and all. He said, do it today. Who will do it next?
Yeah.
If you will not today, the moment will go away. Today you do it. Don't wait for anything else. Coming to that things, we assume we appoint the teachers without training. But it is already to the PGs you are giving experience, teaching experience.
Yes.
It means they should be trained there at that stage. They should be trained before. It is we who are maybe not doing that. For example, in our institution, all PGs are trained as teachers, resident and teacher. There's a program. Everyone has to be trained. I will be very happy if one of the students asks something or add to something, they are sitting here. You might be hearing this term faculty development. Your faculty, it's not that they are underdeveloped, but you are hearing this word. Anything you have to say about that? You have seen what is going on at national level.
Any students over here?
Yes.
Yeah, any student, please volunteer. Introduce yourself. Introduce yourself.
First of all, good afternoon to all the honorable dignitaries present here on the dais and off the dais. I am Tanisha Srivastav. I'm a second year MBBS student here at AMEE Medical College. So as shared with us, the faculty development program. First of all, that's very actually interesting and knowledgeable for us to know that so much that the faculty is going through to give us all the experience and knowledge that we are getting today. I mean, the platform that is being provided to us here at our college does not only involve the education that we are getting, the medical education, but various skills that are being honed. And for that, the amount of training that a faculty has to go through, the continuous renewing of the skills that faculty has to go through is, first of all, we are very grateful for that. That's the first thing. Secondly, us being a part of it and us being very transparent with all of this process is also a very good thing for us because we can also give our own inputs. And knowing that what faculty has to go through to give us that specific education or set of skills, we can give our own efforts, put in our own efforts to actually help them. Like how we can put in our own efforts to actually help them. And the way things, the Honorable Dr. Ved Prakash Mishra sir said, change is constant, obviously. So the change that is happening not only in our faculties, but as students, corresponding to our faculties, we would also change continuously with the developing curriculum or with the developing set of skills that we will get. So I would just like to thank you all for giving us the transparency.
Thank you, Tanisha. Yeah. Thank you, Tanisha. That is something which we really needed. First, I thought when you were saying, I felt like you were very sympathetic. These people have to go through so many things. And you are enjoying because for this is a curriculum. Yeah. That gave me a feeling like that. But later on, I think when you ended it, so you summarized, concluded very well.
You as a pharmacologist, it was shift from sympathetic to parasympathetic.
I thought they observed Dr. Gaurav, the principles of humanity so much they are applying to us. Thank you so much. Thank you so much.
Thank you, sir, for your, I will say, a very successful presentation. It is evident from the fact that such a healthy discussion that went out after your presentation. Thank you very much. Over to Amos.
Thank you, Dr. Dinesh Badyal, for the eye-opener and knowledgeable session. Thank you, Dr. Abhay Gaidhane, sir, and Dr. Swanand Pathak, sir, for chairing the session. I would like to invite Dr. Abhay Gaidhane to felicitate our lead faculty, Dr. Dinesh Badyal, with memento as a token of love and appreciation.
So thank you, chairpersons. Thank you, all speaker.
Thank you so much.
One small
FMCs.
announcement.
Yeah.
After this, I request all the dignitaries to proceed for the
All
inauguration.
the lead faculties. All the,
I request all the dignitaries to proceed for the inauguration of library and SVL. Post that, all the lead faculties are requested to join the closed panel discussion in the boardroom on ground floor. And parallel panel discussion will take place here.
Dr.
So first we will
Ravekar will lead the lead faculty towards boardroom.
Yes.
We are not breaking for this. No, sir. We'll continue with the panel.
So we will proceed with the inauguration of the SVL and library first, and after that closed panel discussion.
I would request all dignitaries to just wait here only. Honorable Chancellor sir is coming. He will take some time because he's not able to walk. 5 minutes maximum. He started from the.
I request Dr. Shuddha Gade ma'am to felicitate Dr. Abhay Gaidane and Dr. Swanand Pathak.
Thank you, sir.
I request Dr. Gade ma'am to felicitate Dr. Swanand Pathak.
So we have
Please, please. We are having, I request all the delegates to please be seated. We are shortly beginning with panel discussion here. One closed panel discussion will be taking place in the boardroom. Another parallel panel discussion will be taking place here. So I request all the delegates to please be seated.
With the continuous inspiration that Vidyadhanam Sarvadhanam Pradhanam, meaning thereby wealth of knowledge is the most precious wealth, I deem it a great honor and privilege to propose the vote of thanks on this memorable occasion. First and foremost, I would express my gratitude towards Honorable Chancellor DMIMSDU Dattaji Meghe sir, Honorable Pro Chancellor DMIMSDU Dr. Ved Prakash Mishra sir,
Join your hands to welcome Chancellor of DMIMSDU, Honorable Shri Datta Meghe sir.
Can I get a handhold? Hello. 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 Yeah. Good afternoon, everyone. I know this was not the part of the schedule, but since the dignitaries across India and abroad have joined, our Honorable Chancellor sir had requested that he will also be a part of this commemoration for the better knowledge of larger public. I know many of you must be knowing him. He is Mr. Datta Meghe. He was 7 times parliamentarian and currently not in the active politics. He was member of Lok Sabha as well as member of Rajya Sabha. Has been a minister in the cabinet of Maharashtra and thick confidant of Mr. Sharad Pawar to begin with. And now he is in advisory capacity to all the leaders in and around Nagpur, Maharashtra. Thick friend of Honorable Nitin Gadkari ji, as well as a mentor and advisor to Honorable Devendra ji Fadnavis, who is the Deputy Chief Minister of Maharashtra. He wanted to just have a look at the arrangements, and I hope all the arrangements in the shortcomings, they are mine. Whatever are the good things, they are because of the blessings of the 2 gentlemen which are sitting here. Without wasting everybody's time, because the schedule is tight and there is an inauguration for which many foreign faculties are also joining. So I would request Tripti to have a quick introduction of the dignitaries who have come so that sir can interact. And following that, I would request these 2 people to inaugurate our new library.
The interruption will be only an inauguration which has been worked out, for which we will be speaking out. All of us, you will be here carrying on with your intellectual sojourn and pursuits and deliberations. Mundane mortals will go out, learned ones will remain here.
So thank you so much. Yes. We are very thankful to Honorable Pro Chancellor sir to grace this occasion. Sir, we'll start with Honorable Dr. Russell D'Souza sir. Sir is coming all the way from Australia.
रसल साहेब आहेत साहेब.
तू हिंदी में बात कर.
आणि युनेस्कोचे हेड आहे. या सगळ्या कार्यक्रमाचे पायोनियर आहे. Yes, एथिकॉनला आले होते आणि आपल्याकडचा जो बायोटिक्स युनिट आहे ते साहेबांनी
सरांनीच दिलं आपल्याला. आणि सरांमुळेच आपल्याला तो AMEEचा सेंटर जो मिळाला आहे तो सरांमुळेच मिळाला.
जो आज आपल्याला सेंटर आहे त्यांच्या पुढाकारामुळे मिळाला.
थँक्यू. डॉक्टर अविनाश सुपे सर.
मुंबईचे सायन मेडिकल कॉलेजचे डीनही होते, आपल्या डायरेक्टर होते बॉम्बे म्युनिसिपल कॉर्पोरेशन मध्ये. बापट सरांचे विद्यार्थी
आणि आमच्या सगळ्यांचे टीचर. डॉक्टर लता रविचंद्रन.
या सर रामचंद्र मेडिकल कॉलेज मधून आल्या, आपलं चेन्नईचं. आणि सध्याचा जो डेंटल एज्युकेशनचं CBDचं डॉक्युमेंट आहे त्याच्यातलं ते ऍडवायझर आहे. फार मोठं काम आहे त्यांचं, ते शॉर्ट आहे त्यामुळे मी मूर्ती लहान कीर्ती महान.
डॉक्टर गीता लक्ष्मी मैम, मैम सॉरी एक्चुअली मैंने आपको देखा नहीं, मैडम इज वाइस चांसलर.
सर हे आपल्या तामिळनाडूच्या, जसे आपलं महाराष्ट्राचं आरोग्य विज्ञान विद्यापीठ आहे तसं जे तामिळनाडूचं आरोग्य विज्ञान विद्यापीठ होतं त्याच्या त्या कुलगुरू होत्या. आता MGR युनिव्हर्सिटीच्या त्या कुलगुरू आहेत आणि फार मोठं नावलौकिक आहे त्यांचं मेडिकल एज्युकेशन मध्ये.
डॉक्टर पूर्णिमा बरुआ.
पूर्णिमा बरुआ सर जोरहट आसाम मधून आल्या. म्हणजे ते त्यांनी म्हणजे आपल्या डॉक्टरेट डिग्रीमध्ये त्यांचा फार मोठा सिंहाचा वाटा आहे आणि त्यांच्या पदोपदी आपल्याला मदत मिळते. पूर्ण नॉर्थ ईस्ट मध्ये जो एज्युकेशनल सेंटर आहे त्याच्या त्या इन्चार्ज आहेत.
डॉक्टर दिनेश बदयाल.
दिनेश बडियाल लुधियाना मधून आले. ख्रिश्चन मेडिकल कॉलेज लुधियानाचा जो सेंटर आहे आणि पूर्ण फेमर प्रोग्राम जो आहे अमेरिकेचा तो ते चालवतात. आपल्या निमंत्रणाखाली आले आणि सध्या पदव्युत्तर करता जी कमिटी नॅशनल मेडिकल कमिशन मध्ये आहे त्याचे ते संयोजक आहेत आणि पोस्ट ग्रॅज्युएट एज्युकेशन मध्ये त्यांचा फार मोठा सिंहाचा वाटा आहे.
PhD चे वायवा घ्यायला खूपदा आले आपल्याकडे.
आणि ही सगळी म्हणजे आपल्यावरती आणि आपल्या इन्स्टिट्यूशन वरती प्रेम बाळगणारी आणि आपण हात दिली तर येणारी माणसं.
डॉक्टर कीर्तना नायक.
आपल्या मणिपाल अकॅडमी त्यातल्या त्या मेडिकल एज्युकेशनच्या इन्चार्ज आहेत, फिजिओलॉजीच्या हेड ऑफ द डिपार्टमेंट आहेत आणि जसं आपल्याला सेंटर मिळालं आहे, देशात 4 सेंटर मिळाले, त्याच्यातलं मणिपालचं सेंटरच्या त्या इन्चार्ज आहेत.
डॉक्टर साहिबा कुकरेजा.
साहिबा कुकरेजा अमृतसर वरून आले साहेब. यांचंही पंजाबमध्ये आणि मेडिकल एज्युकेशन मध्ये खूप मोठं नाव आहे, खूप चांगलं काम केलंय आणि अगदी म्हणजे आपल्या ऍर्डेंट वेल विषय जर कुणाला म्हणता येईल तर त्याच्यात साहेबांचं नाव आहे.
डॉक्टर कृष्ण मोहन.
हे सर चेन्नईवरून आले. परिमलार मेडिकल कॉलेज सर फार मोठं मेडिकल कॉलेज सुरू झालं, त्याच्यात मेडिकल एज्युकेशन मध्ये खूप मोठी कामगिरी केली आहे. परवा मला यांच्याकडे जायचं होतं पण ते कामानिमित्त म्हणजे नाही जाऊ शकलो, तरी पण ते आले आणि अगदी मोठं वलय आहे सर त्यांच्या कामाचं.
Thank you. So thank you very much for coming here. And Honorable Pro Chancellor sir was actually delighted. He was elated and he wanted to meet everyone personally. Therefore he came. We will continue with our sessions. I request everyone to stay here for panel discussion and just, yes.
You, me, Gita, we are moving out. Rest of the things are continuing.
And the lead faculties to come with us.
I'm joining you. Just for the, after the token inauguration of this thing, I'm joining you. काय बोलताय? मी तो बोलतोच आहे सकाळपासूनच आहे सर.
With
2 मिनिट आशीर्वाद देऊन द्या सर.
बहुत से हमारे नागपुर सिटी में है, मैं सबका तहे दिल से स्वागत करता हूँ और जो भी हमने थोड़ा बहुत काम किया है उसके लिए वेद प्रकाश जी, वाघवाणी जी जैसे हमारे तज्ञ लोग ये सब काम करते हैं और इसकी वजह से आज हमारे एजुकेशन में मैंने रिजल्ट में जो कुछ काम किया KG1 से लेके PG तक, स्कूल से लेके कॉलेज और हर डिपार्टमेंट में काम किया है कि हमारे साथ जो काम कर रहे हैं लोग उनके भरोसे हम काम कर सके। आज मैं बहुत बहुत आभार मानता हूँ, आप सब लोग दूर दूर से आए हैं और मेडिकल कोर्स के लिए मंथन कर रहे हैं। मैं सबका आभारी हूँ। धन्यवाद। जय हिंद।
Thank you, sir. I would request Russell sir and madam to please join this program. And request all the dignitaries to continue with the panel discussion and Anaga to take over for panel discussion.
Forward for panel discussion on best practices in competency-based medical education. I'm handing over mic to our panel moderators, respected Dean Dr. Ujjwal Gajpe and Dr. Shubhda Gade. Over to you, madam.
Hello, hello. So very good afternoon to you, and we welcome you back again to another panel of another chain of discussions, which we call it as panel discussion. And we have a very learned team of panelists to take part in this panel discussion. May I invite Dr. Avinash Suppe sir to take his seat on the dais. I request Dr. Purnima Barua to take her seat on the dais. I request Dr. Lata Ravichandran to take her seat on the dais. And the fourth panelist is Dr. Sahiba Kukrija. Ma'am, please take your seat in the dais.
Okay. Thank you.
So a very hearty welcome to all of you from the organizing team of this national launch of Association for Medical Education Networking Centers in India.
Hello.
This panel discussion is all about CBME practices, best practices in CBME. We all are working in institutes where we are trying to implement the different inclusions of CBME at its best. So we thought of why not to discuss whatever we are doing best at our institute on a common platform. That was the intention of organizing this panel discussion. So I start with Dr. Avinash Suppe sir, myself, Dr. Shubha Gade, and Dr. Ujjwal Gajpe.
Myself, Dr. Ujjwal Gajpe, Dean in this Datta Mege Medical College. Good afternoon to all of you.
Now, it's since last 3 years, since 2019 was the first batch of competency-based medical education. And 3 batches we have been taught about this competency-based medical education. So we have our own experiences. We know its shortcomings, the challenges that we made during implementation of all the 11 inclusions of CBME. So in order to discuss all these things, why not to start with Suppe sir? Suppe sir, it's the most difficult task sir, to introduce you. How to introduce a person? How to introduce a person who is an institution in himself, sir? So, Doyen of Medical Education, Dr. Avinash Suppe, a hearty welcome to you, sir. Sir is the ex-director and Dean of Medical Education and Major Hospitals in Mumbai. Sir is also past president of Academy of Health Profession Educators of India. Okay. Sir, the question that I want to put before you is, CBME talks about, or the Vision 2015 document, it talks about 5 roles of IMG. Now, out of these 5 roles, we teach the role of a clinician, even communication. We can teach it nicely, we can assess it nicely, but there are 3 roles which are little inadequately addressed in CBME. That is leadership. Professionalism is also one gray area, but still it can be done via ADCOM. But leadership and lifelong learning, these are the 2 areas which are not adequately addressed in CBME. So can you throw some light, sir, on these 2 roles of an IMG, how it should be taught and how it should be assessed?
Thank you, Shubhada.
I think, wonderful discussion which is going on since morning. But I think if you really see what is CBME has done over the last few years, I don't know, I've been part of every document from beginning, So if you realize previously we used to only look at the cognitive component.
Yes.
Today we have shifted the face of medical education from knowledge cognitive towards attitude and skills. So when it comes to assessment and teaching, as you rightly said, we have been all good in teaching, clinical teaching.
Yes, sir.
Communication, which was not there, but over last 20 years, we have been teaching. The three things which you rightly asked, what is professionalism, lifelong learner, and the leadership. Now see, as a teacher, we should really see that these are inculcated in your practices as well as assessment. Let me first talk about teaching practices. Now, when you talk about leadership, there is no simple talk on leadership which you can really give. It may be just the next week I'll give an oration on leadership, but that is not something which you want your students to talk. You want to give them a role as a primary or secondary healthcare, some kind of a leadership. The whole concept of learner, doctor kind of a student, or taking them into primary center and giving them to work with other health professionals itself is going to make them leader. So the teaching practices have to change completely. It's not going to be a cognitive at all. Same thing, lifelong learner. Now, lifelong learner, we want to make him emphasize two things. One, there's a lot of self-directed learning he has to do. And secondly, he has to update himself. And what do you mean by update himself? I think we are all talking before in a session. Let me give you a simple example, which I think they talked about WHO, those 10 critical skills. 30 years ago, if I want to send money to Purnima, I'm sure, whatever amount of money I want to send, I had to get a checkbook. I had to write that check. Then I have to put it in my bank. It will go to the bank sorting office. The sorter will take it back. Sorter will then have change. It will go to the other bank. They will debit it. Again, it will go and it will get put in my bank after 3 days. And there are 20 people who are involved in all this. You understand my point? After last 10 years, all these 20 people have lost their job. Because we were training people for those jobs and now there are no jobs like this. Everybody puts on mobile and sends it. We never knew 20 years ago that they will lose their jobs. So the new doctor doesn't know which corona-like diseases are going to come, which new technology is going to come. So he has to adopt himself to anything which new comes. So I have to prepare himself for that. Now, if I am to do that, I have to give him projects. I have to give him something which he has to go on his own and learn. And if I don't give him that skill, then I'm not doing that job. So that is lifelong learner skill. So give him a problem which was probably there, or you want to dig and you want to solve that problem. Unless you make people realize, there's no point trying to give PowerPoint lectures, I think. So we have to go beyond those lectures today. They're all available on YouTube and many students will have on their laptops. We need to go beyond and give them those 10 skills of critical thinking, lateral, emotional intelligence. So that is lifelong learning. So you put them into, how many people have workshops on how to search an article or how to search a right article, how to evaluate a proper paper, how to get a message. These are the workshops we need to do for them. So that is lifelong learning. Professionalism, I think a lot was talked on this. I think Gaurav talked about it. Everybody talked about it. Yes. What is the important part is assessment. See, we have to plan our assessment in such a way that we are emphasizing these 3 points. If you just give them a task, they will learn. But if I don't assess it properly, then they will not learn. So for this simple, if I don't put a pat on my student for searching well and doing a good lifelong learner, he will never assess that. I mean, he will not be happy about it. It may not be summative all the time. It may be multiple formative assessments where the universities need to make conceptual frameworks. That's what our role is. And we were indirectly doing it. We were doing it haphazardly. Now it's a time when we need to put a conceptual proper framework and see that all components are there. I think that's the whole gist of what we have to look at this. I'm sure if there are any questions, I'll answer because it's very difficult to say in few lines, and because of the time is running short and there are so many people. I personally feel we have to look at the point that we have to change our teaching methods. We have to change the whole face of our medical education concept, and we have to make a conceptual framework of developing these assessment thrust points in our own assessment point during our regular rounds. You know, what I'm appreciating of my student, you know, like, to be very frank, you have a clinical unit. My residents, if I appreciate him, even in a formative assessment that he has done a good lifelong learner, he has done his own good research, that will go lifelong learning. Everything is not marks or summative assessment.
Right.
There's a lot of beyond summative assessment. So we need to really develop these skills. If you look, last point I want to say, all people talked about assessment and ATCOM. You know, there's a lot of discussion when we created ATCOM. ATCOM module is pure Indian kind of a development. We have nowhere you'll find such kind of a module. So what we thought, let these cases come and let them then discuss. There are two sides to this. Let them go in that fog, you know. It's good to see our students walk in a fog for some time before the clarity comes. Let them go through that mental kind of thing. Then only the ethics gets disseminated down. And the assessment has to be not very rigid. It has to be mainly formative rather than very structured, except for one or two questions. You know, these are some things which over a period of time will become more and more kind of lucrative. And that's the way you will find that these will come. And I'm sure if anybody has any clarifications, I'll try to explain them. So have you understood?
Yes,
There are three basic components which you have to teach in a very different way and assess them at a particular
level. So it can be made a part of continuous internal assessment by including it in the formative assessment.
Formative assessment, some university frameworks.
Yeah.
See, we used to do this all when we used to do, say, clinical cases, but it was a haphazard, unsided kind of a thing. Now we have to try to make it a little more formalized in a framework.
Yeah, okay. That's good. Very nice suggestion, sir. Of course, everybody has to implement on that. And sir, there are certain strategies like Medicon. Medicon is a conference organized by the students for the students. So can it be made compulsory sort of a thing? We will come to that later on, sir. Let ma'am ask the second question.
It's my privilege to introduce Dr. Lata Ravichandran. Madam is right now Dean Education, Professor and Head of the Department of Pediatrics, Sri Ramachandra Institute of Higher Education and Research. Important academic qualifications being she is Diplomat of National Board of Examination, FAMER, ACME, MD in Mind-Body Medicine. She also has in her credit International Fellowship in Medical Education. Academic appointments being she is Dean Education, Professor and HOD Pediatrics, I have already said. Co-convener MCA Regional Center for AMEE workshops, as well co-convener MCA Nodal Center for Faculty Development and also NAC assessor. She has multiple committee assignments, many research projects, as well as publications in her credit.
Thank you, ma'am.
Now, when we discuss so many inclusions of CBME, early clinical exposure, ATCOM, SVL, these are in regular practices, ma'am. When we talk of electives, we started CBME from 2019 onwards, and this is the first batch which will go for electives. So which areas you will suggest for electives which will be highly beneficial for the students?
Electives are electives. We need to give a range of varied experience to the students. There are two blocks to it as per the GMR. The block one, which is more for research oriented, where they do basic science. Probably they do a research, not like that, a research experience under a scholar. And the block two, laboratory experience that comes in block one. And the block two, which is a multiple clinical experience as well as community and urban center experiences. Just going back to saying, yes, this is a big challenge. Everybody is talking about it because we are going to go into that mode now. Students have finished their part one, and before they start their part two, they have to. But this requires planning from the day we started CBME. Though it may look, electives may sound very flexible, lot of planning has to happen because we have to open very variety of departments into this and into our level of thinking. We can, get students and ask them to go there, but they simply will just come without learning or the experience. The purpose is that we give a bird's eye view of what they would want to go in future. So they explore themselves and find some sort of an, an excitement that they would want to come back to that. And of course, the research is something which is non-compromised and basic science component. Under a supervisor, what is it to feel to be a part of a research? This is just, getting the taste of it so that, they get excited about it. But the whole structure of this doesn't work well if you have not planned it well. While we are opening out electives, we should be very transparent in which are the departments they are going to go and how many students will be taken. And this has to be opened out. We did it in online. We did even a mock one to see whether people are even able to opt for it. But even before that, the committee for electives were formed because they started the work much when the CBME itself started. Those committees were the ones who were working on the different block departments. They communicated with the licensed person, the coordinators there, and derived the brief objectives. While it may sound brief, it is very difficult to make those brief objectives because there are departments which will give an experience to a student which is much more and not needed at the MBBS level. So that vetting will happen over 1 year or even 1.5 years before we even, and the communication also educates the department, the student, be prepared, they're going to come. There is a coordinator from here and there is a licensed officer from there, and you're expected to do this much only. And not only that, there is an additional responsibility of them being observed. It's a supervised experience. They are to be observed and they have to document their experience with the patient or with any other learning experience they have, like a portfolio, and verified and certified by that person who's supervising, which means these are met. Let's say there is only one objective with which they are going. There must be a certification from that licensed person or the supervisor that it is met. So while electives is only 2 months and it looks very flexible and very beautiful, if it is not structured, it is not going to be serve its purpose. I can give an example of such an experience as a student I had. They used to send us to King Institute. And every community medicine we used to, I was an MBBS student. This was some community experience to go to King Institute. All my seniors, you say, go to King Institute, there will be an ice cream parlor in front. And there will be a train coming inside the track and there will be all greenery. And we used to use it like an excursion and go enjoy and come. The purpose was to only observe the BCG vaccine. So that actually is just a comparison to say how structured we have to do our electives.
In 2019, I think elective module was published. I remember we worked on that. We started the published elective module, which is available on the NMC website. And what she rightly said, we need to think about it. What are the objectives? What are observable? It may not be we may follow, but we should have some structure to this. Even if I feel some of you may not have worked on this, the simple method is whenever a student comes to you, first sit with him for about half a day or about 2 hours. Find out what are his needs, what are your ways of looking at it, put it down on paper, give him some direction. Over next 1 month or when you observe him, again have one meeting in between. And at the end, again, ask him to write reflections and have some projects. So even if you are able to do that, I think you will be able to achieve much more. If you have planned it well, it is good. But see, these are always these with guidelines. Classically, I realized now we have so much of done on this. Most of the time when we go to the teachers, there are 30-40% teachers have read about it. 50% people do not know that it exists. And 10% say they are not even aware of that this is published. So I think that's the kind of faculty we have. So it will gradually seep in the system. And as Lata rightly said, as the experience will happen again and again, people will improvise it. And see, I think it's a question of we have just put in something which will be improvised by everyone. There are so many there are so many intelligent people in our system. They will all improvise and take it further. And I'm sure we will be able to achieve what was expected out of that.
So I would like to say just one.
Yes.
I have a colleague in some other college that I'm talking about, and he's also FAMER fellow and well learned. So Rajiv, I'm talking about. So I discussed with him about electives, how to go about it. He said, Sahiba, I've asked all the departments, anatomy, physiology, biochemistry. First, they did a lot of training. What is elective all about and how to make the modules, like ma'am said. And eventually he has told each department to come up with one elective. It is up to the students to actually then see what they would eventually go into. Why should not anatomy have an elective? Why should not physiology have an elective? So that was also a very good point that I learned from him. And that's how then we are planning to, go about. So because we were thinking, okay, all clinicians and maybe laboratory sciences, but there is so much in physiology. So there is so much in anatomy that the students would want to learn. So we were not thinking on those lines initially, but by talking to him, this is something that really was very nice for me. Yes.
Itself can be one of the electives. It's a very unique kind of a lab that Tamege has. I think you need to have a focused area in that particular specialty to develop, learn. In fact, I personally feel students should work on a project where they should bring out a publication. I think the sky is the limit for these kind of.
Right. Yeah. If yeah.
I both sisters were very poor in mathematics. But at that time, they had opted for music. He belonged to family of musicians. But they are doing extremely good in that field of music today. So what are the long-term implications of what do you, how do you propose? And how do you anticipate that the child will go for this elective and he may specialize in that? This is one question. And second, are you taking the aptitude of children towards opting for elective?
Sorry, want to.
I'm going to give a clear answer to this, very clearly to this. So when I was in a 12th standard, I think at that time it was inter science. My college took my aptitude. It was a 2 days aptitude test. They looked at art, they looked at engineering, they did. But there's a very poor evidence in the literature, if you look at it, that the aptitude and the ability of the person really makes it a good, in the skills of yours. And this is a science is not so well developed if you really look at that way. But what is important is that if you look at all over the world practice, that if I want to become a surgeon and the kind of life I want to live, there was one girl with me, there was a very nice young girl who accompanied me, and she asked me a very nice question while I was coming to this place. I think her name was Jui. She asked me, I want to become how do you decide that I want to do that further career? So my answer to them is very clear that electives help you to understand a particular specialty much better. You understand the intricacies of, otherwise, many of these have auras, and cardiac surgeon, liver transplant surgeon, neurosurgeon, or something. So if you go into that, you understand their intricacies, their failures, their limitations. Also, you understand whether I will be able to like that specialty or not, whether that interests me or not. If you are able to get that answers, I think it's enough for me to really take an elective.
Just to add on, okay. And just to add on to this, in our college also, we have started it this way, that we have invited nodal persons from each department. They have come, they have understood the entire thing, and they represent their department, and they're coming up with their own modules on electives, which will be handed over, although we are late, yes, it will be handed over to the students, it will be displayed, and then we will have a kind of counseling. Like sir said that we should spend some time with them, look into what their aptitude is, and then give out the elective in which they would want to follow. So this is one thing. And regarding this, whether can you see that elective has been placed in a very strategic time? It is between phase 1 and phase 2. So you are already, the students are introduced to almost all the subjects by now. And so they can have some idea about what they might want to pursue. So there are two things. Either I would go for this, that would consolidate that. And the second thing is that try that, even that is also there. So electives really, that is the basic idea, isn't it, sir, while devising the module that was.
No, another point is that if they find that some areas in them are weak, somebody may be weak in communication, somebody may be weak in a surgery, somebody in that, then he probably time to strengthen those things, consolidate that, look into little more details. You know, that's another approach to this. That if I find myself weak, I'm not done that way. Maybe this is the time you can go in and try to consolidate yourself. So these are some, you wanted to say one-liner, Sahiba, right?
I wanted to say one liner, it's like Dr. Purnima already said a little bit, that when you want to make a person run away from them, that's I did with my son. He wanted to be an engineer. I said, okay, you join FITZI. He said, I don't want to be an engineer because he learned he was not good in mathematics. So sometimes you wish you want to become a cardiac surgeon, sometimes when you actually are into that situation, you realize you're not meant for that. So like she already said that you can also, the students can identify that this particular thing I might not be able to do.
Actually, ma'am,
They
that
may
is
not
one
be-
of
They may
the,
not be very mature. You know. I remember to understand this. So we have to handhold with them. That's very important. At that particular age, it's not sometimes you underestimating them or something like that. I personally feel you have to talk to them, be prepared yourself for this if you want to do it. I mean, normally I would not say that you cannot do it or something. I would tell him, if you have to do this, you have to change your attitude and prepare yourself in a little different way. Most of the students will do it. Sometimes, this is a very common thing. A student comes to me as a first year resident in a surgery, and then he's not able to cope up with the work. And sometimes, they give up. It's a loss of seat. In a government college, in a KEM, seat lost is something which I feel really bad. So then many of them used to come in internship work with us. Some of them used to talk to us, see the kind of work we are doing, the kind of coping they have to do, the research component, these are the gaps. I think there's a lot of things to the elective than what you want to. And there are a lot of things which I would like to do. I would have never done it before. So I would like to do that. So that's the option. So elective has a very big canvas with multiple kind of kind of areas where you can really think about. Idea is that how do we use it? Don't make a run of the mill kind of thing. Itne students inko allot kar diya, my job is over. Now it has to be a process by which I think there are 2-3 audience questions we'll try to answer.
actually, yeah.
Whether you decide.
No, ma'am, during lunchtime.
Profession review. But have we really taken the things about the financial aspects of that profession? Because that is how we
Are so right. I'll tell you, you are so right, but we had a lot of discussion on this. Many people refused. I was to saying you should have a share market also, no issue about this. What I personally feel, see law, if you go to the law curriculum, they have a complete module on how to negotiate your fee with your client. They charge 2 lakh rupees for standing for 10 minutes, even if it's lost, and nobody blames them if they have lost the case. And some patient fails, he will start hitting a doctor. That is because they are never trained into that negotiations, basically. Look at that as a different aspect. So I personally think we should be very wide enough for this, depending on that. But see, biggest problem when you are putting a framework like this, concept is one aspect, how people utilize is another aspect. See, I have enough examples where people have taken holidays with electives.
Exactly.
So we need to have that framework. People will not. Otherwise, इस 2 महीने holiday में मेरा uncle USA में रहता है, मैं उधर जाके, how many people used to misuse all this? So then we restricted that it should be in the same city. They have to report to their teacher. There has to be a framework of reflections. See, we have to think about implementing it in 612 medical colleges with 1,20,000 students, and you have to see that people are not misusing that kind of. It's not so easy to do it when you are working at that level. I understand as a concept, yes, but many of these can be taught in a lectures or giving them concepts or something like this. But as you rightly said, yes, we need to open up those boundaries over a period of time. I won't mind people going in IIT and working in a medical equipment research, absolutely fine. But then I want some framework. I want some kind of things which have to come out of that. I need some kind of a report or some kind of an adherence to the whole.
So I just start one step. My observation was the end result for this elective was I was talking to a previous student from first year to second year and final year. I realized that the end result can be one of the two also. One of them is one of the students says that every time I finish with the subject, she says that they go into a phenomena where they are in medicine. They said, I want to be medical, no, I want to do MD medicine. I want to do. And sometimes we have a inbuilt pressure from some of the students, not all, whose family or maybe
Nothing more.
so they are in that particular setting where they have to find out that if my father is an orthopedician, am I CADA to be an orthopedician? So can I really take that elective to a stage where they will find out that is it really suitable or I'm not?
Actually, I would love to add some adolescent development along with it. The career concept starts coming only in that same age where they are actually getting exposed to these electives. They will have, excitement. They will have some repulsion. Then they go into concrete formation of their career decision that will come towards their internship. Let's put ourselves into this. How did we come into conclusion that I had to go into this field? There was some experience which are neither documented, but within ourselves, something which has been happening. So it is very normal for them to get excited, even by their friends telling, I went for that elective, it was very good. They may even be liking some person who's teaching over there and they may want to go to an elective. That's where the role modeling comes. But finally, when it comes to their own aptitude, it is skill-based or thinking-based, the major surgical versus and the medical field decision will be made. There are people who will, I can probably do some research and say, those who have both have gone into certain fields which has got both. So it is finally, it will tend towards that. But this experience gives them to
a good surgeon
Yes, sir.
has good cognitive, good hand skills, and good attitude.
No, sir, I'm not talking about that. I'm exactly coming into the this thing.
I think either is.
Yeah. I'm actually supporting what you're saying only, sir.
Hello, sir. I'm Dr. Abhay. I'm the Dean of JNMC. Regarding electives, most of the things have been answered, but when I asked the department to give me the list of possible electives, what they can plan, what I could see is most of the topics are related to the core theme itself only, more in histology or more in some physiology or something. When I was looking at today's deliberation in morning also, and I talked to many people, what I feel that we need to go beyond this, because there are a lot of new opportunities are coming for medical graduates when I look in the market. So, and some of the skills needs to be taught very differently, like professionalism, empathy, and all those things. So I would just like to know, is there hope to build electives in arts and cultures? Is there a...
Currently, no, but over a period of time, yes, it will happen.
Like medical tourism, medical writings?
Currently, no, but after a period of time, it will come.
And
currently, no. Currently,
no.
it is not acceptable, but over a period of time, it will be. Currently, it is not acceptable. No, currently, see, this is let this first few batches go. Let's see how people adopt to it. If there's always a need and demand from the people, then probably that time NMC, whoever is in the committee, will open it up. We were saying we will have some kind of a establishment of this concept. Once it is concept, like you said, people are currently just trying to establish this concept. And she rightly said, people are thinking about knowing, we are trying to think about this concept. But as the time will go, people will come out with more focused topics. And that is a time when you will find that people will go divert, they will have mixed, like see, if you look at John Hopkins today, look at Howard today, they have broken all faculty walls. Engineering and art and culture. I think one point which I thought was very important to make in today's morning's deliberation, every college should have a department or a cell of humanities.
Correct.
Humanities today is one of the most important, which will encompass many of these aspects you said. Like you said, art.
Yes.
In fact, what you said, Lata, humanity cell should have a counseling cell with everybody and they should discuss with your own performance and do that.
Definitely.
I thought I
I
started
agree with
Humanity
sir.
Cell in 2015 in KEM. After 7 years, I am so happy the way the cell has gone and the kind of discussions happen and the way students have learned through that. I think it's time we should think out of the box.
Yeah, just one last thing. Is there a requirement for assessment of electives as well as per CBME?
Yes, yes.
Yes.
It's given in the book.
Sir, I would like to apprise learned dignitaries as well as the gathering. Our reflections regarding the CBME inclusions, like if we talk of alignment and integration, we are following it. We have block teaching and many more good experiences with that also. Early clinical exposure long back before 2019, it was started in our university and it is also very effectively practiced over here. Same is the story with ATCOM as well. Initially, students' attendance was less, but now students are liking it, accepting it. Adaptability is to a higher level for ATCOM in our university, both the colleges, JNMC as well as DMMC. Regarding SVL, students are showing much more interest. Feedback is that they want more and more sessions of SVL. Continuous internal assessment, of course, there is a bit gray area because of time constraint, but we are practicing it that also. Sports and extracurricular activities, that is also effectively being practiced here. What we do is we have divided it into two parts with the guidance of Honorable Mishra sir. One part is we see the hobbies of the student, one group. Another group is we do psychometric analysis of the students and we try to get, yeah. So we try to get their interest and then we are working on three aspects. First, the model will go for individualization, second, internalization, and finally institutionalization. So with this, we will be proceeding with this inclusion, that is sports and extracurricular activities. We are very effective in SDL, self-directed learning. We are taking much more sessions on CBL, museum aspect, as well as library. So we have own modules of SDL in all these areas. Real life situation, of course, it is ongoing thing. We are finding electives, like concept was introduced prior, CBME concept. But then operational wise, function wise, we are very comfortable with all these inclusions, which I have said right now. But electives, we are doing the task of electives since 2 years. Many of my faculties will agree with that. Of course, as Gaidani sir said, initially we were with theme. We tried to take the topics from all the subjects. And then at that time, we had decided that 1 month should be basic sciences. The elective should be framed in such a way that 1 month should be planned for basic sciences, then another month should go for applied sciences, and there should be connectivity between these two. Even if we say MBBS curriculum, there is basic sciences first and then the applied sciences. So we should have electives in such a way that we should have a basic component and followed by a clinical component or the applied component. Then we are with the forming of modules, but then we are finding all these things quite challenging. First, to go for the themes, what exactly, how we should narrow ourselves towards the theme from the subjects. We have, of course, many of the themes from all the subjects, basic, para, as well as clinical subjects. But even now we are in the process of forming the modules and how we should sensitize the faculties. We need to sensitize the students. What are the objectives of the electives and how should we take it further? So I think my colleagues will agree with all these things. We are already doing it.
Great.
No, you are a new college.
Yeah.
This is a time to establish paramparas. I feel the whole traditions or thing, this is a time to do it. And you have so much of wisdom. There are a mix of young teachers with experienced teachers and everything is there. This is the time to take best practices from your institutions, back institutions, and then try to develop a system. And let them, first 5 years or 6 years, you develop a system, it will go on long way. It develops the whole culture of an organization. You know, see, every organization has 4 kind of frames. I don't know, you have heard a book, must read a book of Lee and Goldman, frames of organization, reframing organization, they call it. So the first is a structural frame, which is fairly common. Second is HR frame. You know, human problems will be there everywhere common. You know, there are about 15% people are overworkers, 50% people are average and 35% dekhte hai, those people who never come. I'm sure every organization is own culture. The third is a political frame. And the last frame is a cultural frame. Now, MCI and all will give you structural and HR work, but the political and cultural aspect of an organization can be built by you all. And that's what depends after 10 years what your college is going to be. See, there are 612 medical colleges. Why do we need the ranking? All are not same. And what depend they are same. They depend on what is your culture, what is your ability to produce, political frameworks, the kind of commitment. So all that we need to start working. I understand it is not so easy in the first few years. It's one of the most difficult thing for people like you, Dean and everybody, because you have to really coordinate so much at this stage. But once you do it, you will see the fruits after about 3 or 4 years. And that's the time you develop, and you are probably in the best situation because you're developing CBME, you're developing your organization, mingle it together and try to put, you don't have history currently. So build your history. I think that's the message I would like to give you. And that's an opportunity, you know. Don't consider it as a roadblock. Consider it as an opportunity for you to develop a history. So after 10 years, if I'm there and come, you'll be able to tell me many more things which you will be proud of.
I will just share one thing which might help specifically with regards to the electives, because I see a little concern in all of them, which it worked, bringing people together and conducting a workshop. This is over and above what sir was today talking about, focused workshop. This is not about the curriculum implementation that went very fast. Everybody was there. We are only concentrating on the undergraduate teachers, but we are forgetting those who are all part of the electives are also coming into the fold of undergraduate teaching now. So conduct a focused workshop for the faculty as well as the students on only electives. While electives is simple and has to be little bit, more easy, constructing it is very difficult. So the most important thing is bringing people together. Get a WhatsApp group of all the people who are part of the electives. So anything which comes, they will start putting the concerns over there. Immediately can sort out. What I'm saying is, for us as an undergraduate here, we are used to it. Suddenly bringing a super specialist to come and teach at the undergraduate level is a challenge. But the moment they understand what you're doing and a part of a workshop, immediately they will grasp. And they will come down to that level of what they have to give to the student. They will understand. They are doing revised basic workshop, but they are not directly involved in the undergraduate teaching. So you could do 1 or 2 focused workshop only to orient them towards what elective is. Because the expectation should not also be too high. Because the students, if they don't know what they have to expect out of it, or the teachers have a very high, they be, oh, undergraduate, I'm going to show everything that is happening over here. There might be a mismatch in this whole thing.
Very nice and wonderful suggestion, ma'am. Definitely a focused workshop on electives for this area.
Yes.
Now, as we have spoken about the challenges of these electives, another challenging area in CBME inclusion is ATCOM. So for that, I would like to put a question to, hello. I would like to add a question to Dr. Purnima. Dr. Purnima Barua is a professor of microbiology, and she, at least institute ka naam to batao main. She belongs to Government Medical College, Jorhat. She comes from a beautiful state of Assam, jahan beautiful Brahmaputra behti hai. I always remember that. I had been fortunate to visit Purnima's place for attending NCHP 2017, I think. Yeah, 2000. So she's a convener of NMC Regional Center of NMC, also a FAMER fellow. Now, elective is a upcoming area. Okay, this will be the first batch where the electives will be implemented. But there is another challenging area where we are facing a lot of challenges. Everybody is facing challenges. That is ATCOM, another gray area. So Purnima ma'am, can you brief us on what are the challenges that you are facing at your institute?
Okay, thank you so much, Dr. Shubhada. If I have to tell you about the challenges, then probably I would like to divide it into, I'll take in the systems approach. Let's talk about the input first. That what do we have when we are delivering or implementing ATCOM? What are the things do we have in hand? One is the very beautiful module, the very exquisite module that we have of ATCOM. Secondly, to deliver, we have teachers who are trained initially for 1 day and later on it has become for only 1 hour. That is the challenge. That is the
Operational level
challenge
challenges
that yes,
actually.
we are expecting that attitude, ethics and communication to be taught to the students by teachers who themselves are, I won't say inadequately, but yes, taken by, you can understand.
Yeah.
All right. So the first challenge is that the number of hours that we are giving into this faculty development in ATCOM for the teachers must be increased. Must be increased. It must be increased so that the teachers who would be implementing or delivering these ATCOM sessions, they very well know about what they need to deliver. Number one, that clarity has to be there. I remember a while back with Prakash Mishra, sir had mentioned about the 3 aspects of a teacher. One is teacher, one is a professional and researcher. So like we have courses for like RBCW, ATCOM, ACME for teachers, we also have this biomedical research now, which is very compulsory for the teachers. Why not a bioethics course? It will go a long way. It will go a long way because see, when we are talking about ATCOM, we are talking about 2 axes. Number one is the y-axis, vertical integration, x-axis, horizontal integration, and there's another axis, z-axis, will go directly to the heart, affective domain. And unless we as the teachers, we are convinced about what we are delivering, the students would not grasp. And mind you, the sessions are designed in such a way, which also says that we should be having a faculty who would be training a group of students longitudinally so that we know how they are developing. For example, today I take a session on autonomy and maybe shared decision making. Tomorrow, those students come to, or a different set of students come to me for, or goes to sir for the same autonomy and shared decision making. But what happens is, what about the medical errors and negligence? Am I not supposed to know that as a teacher? Because my session is only about autonomy and shared decision making. So it doesn't make much sense unless we as teachers, we are through and through well versed with the different aspects of bioethics. Number one. So this is a challenge that we face. And the second important thing, if I talk about the process now, that who is going to take the sessions? Who the immediately आज ATCOM का session है कौन लेगा? It is like the medical education unit or the Department of Medical Education. Well, that's fine. Initially, the trained person, faculty can come in, but always what we try to do is rope in the other departments also, or the faculty also, who would be a part of it for hand-holding. Because ultimately it has to go a long way, and only the Department of Medical Education or Medical Education unit faculty, it may not be very sustainable. So you must have the other faculties also to be roped in. Another important thing that I would like to highlight is when it comes to summative assessment. See, when we talk about ATCOM, I would say, or rather we all say, and even the guidelines or the module says that it is mainly about formative. The essence is formative assessment. But there is an element of summative assessment also, which means university. Now the question is, from which module, or for which discipline that question is going to come from. So again, that we have to decide beforehand. What it means to be a doctor, what it means to be a patient, doctor-patient relationship. Yes, anatomy se aayega, physiology se. So for summative, sometimes it requires to be earmarked. Why I'm telling you? Because you may leave it open, but sometimes the same question can come in all the question papers, which means that essence of, again, having, earmarking or picking up, yes, the universal, the universe of that element of representation may be lost sometimes in summative. So these are some of the challenges. And finally, every institution must have their own mandate of what professionalism or what kind of attitude or the cultural, socio-cultural things that they need to the students to learn. So that is very personal. And we know that ATCOM, when we talk about attitude, ethics, or communication is very generic, of course, but a lot of things are, again, very contextual. And lot depends upon the teacher's own that implicit values, as well as the students' implicit values. And ultimately, that is what gets reflected when we talk about or we come to patient's outcome in the long run. So,
if you see the structure of ATCOM, I don't know how many of you really understood and thought about this. We have structured 3 modules like attitude, ethics, and communication, and we have taken them at a increasing proportion of complexity. You know, that is the way it has been built actually. So, like say you take a stream of communication, it will be initially your peer communication and how foundation. Then we have gone into little higher. And then last year we have gone into say deaths and all that kind of. Same thing has happened with the ethics, same thing happened with the attitude. So we are trying to begin with a basic thing and go little at a higher level. Now the question is, any teacher can take it. That was an open thing we kept. But people need everything on paper. But as I said, these are the things which have to be locally worked out. Even the assessment also has to be done by the universities. They have to develop their own structure and do it. Trying to be too prescriptive for a whole India is very difficult. So that is a weak portion of our outcome module where we have not really given a framework of this. But I personally feel this has to be worked out by the colleges. They would really do it, and or the universities, because assessment is there for we can only give that.
I think, sir, it is not a weakness, it's a strength because it gives immense flexibility to the institution.
Exactly. ATCOM module is not fixed all over the country. It's flexible.
Lot of flexibility. It's completely.
The universities and the colleges can think over flexibility. What we have been doing is that we have connected ATCOM module with the communication skill lab. So the communication skill lab takes care of that ATCOM module. We teach ATCOM through the communication skill. We have a team. We have a lot of trained faculty with us. And there's a lot of flexibility. You can adapt locally with your culture, with your social background. You can adapt to the stories may not be the same story.
Exactly. And one more important, yes, just one aspect of this ATCOM module, that the debriefing part is very important. Because the students, they come up with such a good, they have their another level of thinking and inputs. So debriefing is very important when we talk about the ATCOM.
Sir, ATCOM module is so beautifully designed, so it's very easy to implement. Only thing is what we need a motivated faculty to take the task. So what we are doing at our institute, under the umbrella of medical education unit, we have phase coordinator for each phase, and with them we have given subject coordinators. Like for first MBBS, we have one faculty as a phase coordinator. With them, we have faculty from anatomy, physiology, biochemistry. They take care of that module for the first year. Similarly, we have divided those competencies subject-wise. Like respect to cadaver is very much related to anatomy, but rest of the departments, randomly we have divided them. And we are assessing them in the question paper on those subjects only. As far as theory is concerned, in the prelim as well as in summative examination, we have given fixed weightage in paper 1. So we have developed our own module and we are doing it very successfully. Yeah, and this is very nicely designed and it is so clear-cut. Guidelines are given. It is not complex at all.
Talked about sports and sports time and that. No, I remember in 2012, I wrote curriculum. That time I put some few hours on yoga. I mean, that time yoga and sometimes sports. And Times of India gave a big news that medical students now will play with mat and bat. So there was a lot of criticism, and then they asked us to remove that section. And then fortunately for our Prime Minister Modi ji introduced yoga. So again, it was introduced. So, I mean, you have to think about so many other aspects of this when you normally work on this. But There are so many things. I mean, I think, see, I remember when I created first ICMR, we created an ethics studies. I think we case studies we created. So that time I realized that there was a debate. Some IMA called me for debate saying that this is something which is not to be really taught. This has to be role model. But see, as I told you, the financial aspects, then how to really deal with the financial aspects of the patient is something which we have not really looked into at COM. We thought that is something which is a lacuna which can be really turned on. Leadership has enough, but I think these are some of the aspects which we have done. But I mean, it's okay. I mean, this is an evolving model. Somebody will, you will bring ATCOM 2 model. I'm sure it will be better than. I think.
Can we move on to the next area and we can further go back to this?
Just one more
Yeah.
thing about ATCOM is again like electives or like any other thing, it requires immense planning.
Immense planning.
It requires immense planning.
Lot of
because-
brainstorming
Yeah,
also. Lot of
brainstorming and because students go out and interview the doctors in the clinical side, they should be aware.
Lunch break and inauguration. So one, yeah, Sahiba ma'am.
I'm
Any
happy to introduce Dr. Sahiba Kutreja. Designation is professor and head biochemistry, MEU coordinator, dean academics, lab director, director of biomedical research. Affiliation is to Sri Guru Ramdas Institute of Medical Sciences and Research, Amritsar, Punjab. Her professional achievements are 56 research question. Yeah, only it's a short. 56 research publications are there, and she has 3 chapters in her credit, 2 chapters in the book Humanities in Medical Education, and 1 chapter in the book How to Write the Thesis and Thesis Protocol. Last 5 minutes. I'll be thankful if you'll be sitting. I'll be thankful to the gathering. How are you incorporating alignment and integration module in your academy?
Actually, ma'am, it has already been given by the MCR how it is supposed to be incorporated. We took the same guidelines, though when we started with integration, that time it was not released. So now that they have already given the topics which can be used for this, but when it was not introduced there, then we, first of all, as everything else goes on, a lot of training was done initially. And then we brought in all the clinical heads of the department and other departments, and we were able to narrow down 2 topics which had competencies from each phase, because this integration has to start from phase 1 and carry it on to all the phases. So those and the topics which had maximum competencies, they were first sorted out. And initially, for the first batch, we just had 4 integration modules. So later on, those modules were built up, and then we were able to pick up faculty who was interested, who were more oriented towards the medical education. So they helped us to build the modules. So it was like we were already told that we need to have participation of all clinical departments, because they need to know eventually what has been taught from basic onwards. So the modules were built, and eventually the competencies were brought in, and then we were able to align those competencies depending upon whether they were to be dealt in phase 1, and then which were to go for phase 2, and then for phase 3 and 4 later on. So this has been done during phase 1 only. Everything was decided and a linker was introduced, and eventually that module will be carried on till phase 4, final year. So for next year, we added more modules like we were told, and so they will be carried on. That's how actually we did. But we have a lot of challenges in doing that. The faculty, the clinicians were not very into, okay, we are not going to come and, and yes, so they were not very apprehensive. Okay, what is our contribution at, phase 1? So we were just saying, okay, the faculty will be teaching. It is not the integration of the faculty coming there. It is just the integration of the topics that we are discussing. So you need to tell us what all should be introduced. At least you should know eventually what all has been done up till they come to you. So they give their inputs. So now, so eventually in 3rd phase, they're coming and they're taking the sessions. But another thing is, I would like to highlight is the attendance. So suppose I have to go and take a recap in pre-final. So students know that biochemistry is not going to get the attendance. Where does the attendance of that particular recap session go? So that is something we really don't know. For that 1 hour, the students are coming. But where to give that attendance? They will come for the attendance of ENT, I, and everything else. But if I have to go from biochemistry, I really need an answer to that, because we don't know. We just keep that attendance with us. Where to put that attendance? And if during that recap session, if a senior teacher goes and takes the session, okay, the students, most of them will come. But if the moment you send a junior teacher there, so that they are not, they don't know, their significance is more focused on taking the attendance. So that is something that in integration, yes.
I think the local principal and your alignment and integration team should decide where the attendance will go. We have kept it very flexible. I think we don't want somebody to own kind of that attendance. I think you can decide. In fact, I mean, we have to be little more flexible also. If somebody is finding shortage of the attendance, you can give it to that. I think it's okay. I'm okay with that.
Yes, sir.
It's not very rigid. It's a university and college decision.
See, I will just share what we did. We took a common all 20 sessions and equally divided between the exam going. We gave it like that. That we did.
Where deliberations were more required, ma'am, in alignment or integration?
No, in both. Actually, yes, both. Because the sharing part, if you talk about, no department wants to give their lecture. So there also it was made to understand, you know, we need to give away with the redundancy. And ma'am, it has really helped, because initially lots of things were repeated at every phase. Because, for example, if I have to start teaching the renal function test, before this integration actually came in, I would ask the students, have you done something in physiology? Okay, till now they have not covered, because that time there was no alignment. So you take 2-3 lectures just doing that, which is actually a waste of time or waste of lectures. Similarly, if you talk about in clinical departments, for even in medicine department, for example, they were initially not aware what all has already been taught to the students. So they also almost waste 4 to 5 lectures on recaps, which is actually not necessary. Another thing in integration that I have thought very important for students' perspective is that they're continuously linked to that topic. So they are like, somebody is coming in lower phases, somebody is coming from higher phase and telling them that there is a connect, there's a clinical connect. You know, similarly, when they are going to higher phases, they are getting recaps. So they have not lost a connection. If I talk to a 2019 batch, they're actually connected to that topic very deeply. It wasn't there previously, because they are moving up and down. They are being connected from all aspects, all departments, horizontal and vertical. So that is
Integration is that students should ask questions to all teachers.
Yes.
Because sometimes I realize that with a topic like TB, community medicine teaches differently, then clinicians teach differently, surgeons teach differently. Somebody gives 6 months, somebody gives 9 months, somebody gives, and you find everybody has his own way. But when you come on the same platform, that's the time students should ask very clearly. So this is what is the problem I'm facing. I'm being taught differently at different places. What is the really right way to go about?
Yeah.
And I think students also should get so much of engaged that they can ask questions. I think that's the whole point.
So integration does help engaging the students, and you know that student faculty gap has also been broken up because of this integration. And I think faculty is also coming closer to other faculty from other departments also because of this integration. And as a basic sciences teacher, I think I have learning a lot. I have a lot of learning to do with interacting with the clinical departments. So it is not only developing the students. I think the faculty is also being developed in through this particular module. Yes.
In our institute, we have also designed alignment and integration modules. So we have a bit deviated experience regarding this. We had to do a lot more work for alignment part, rather than the integration part. Regarding integration, we are not opting for faculty calling, whether it is recap or reinforcement or another part. But we are designing PPTs or learning resource material in such a way that they become aware whether it is alignment or integration, whether it is sharing, nesting or correlation. Correlation, we are not touching that much, but yes, sharing and nesting. So our learning resource material are very effective in that, because calling faculty, it itself is a challenge. But when we prepared module of alignment and integration, it required nearly 2.5 months for all our faculties, pre, para, and clinical sitting together. We have only 2 batches right now. But it took nearly all working days, 2.5 months to design these modules. Then second thing was we prepared block teaching. And it is effectively running. We got informal feedback from the students. So here only alignment part was challenging. In our times, the spacing was quite long. जैसे real अगर physiology में हो रहा है, created a block. So we have created 11 blocks with regard to alignment and integration in first year and 22 blocks in second. And those are, and we have still gone ahead. We have with SDL so that then we keep them save this learning in the SDL and then we show them questions in learning. So this is in first year, this is very effectively. In second year, we don't have early clinical exposures. So that becomes all connect with regard to alignment. Second development we have done is first year alignment and integration. Subject wise, we are having same objectives from that form with community medicine. In second year with forensic medicine. And third year with psychiatry and last year with medicine. So subject wise, we got that alignment and integration with that com. So these some of the areas, even apart from that, we are planning to integrate early clinical exposure and so that way we are trying to move ahead with alignment and integration. Yeah.
I think don't just allow it to happen. You make a document
Yeah.
and see document which is a revisable.
Yeah.
You know, see what happens. Many of these ideas we work out, we don't publish it.
Yes.
We don't put it on the website or your document, and then those ideas die down. You publish it. Don't be so rigid about those documents.
No,
It's
of
ready
course
for
not.
revisions.
Yeah.
And so that you add your wisdom as you grow.
Yeah.
And try to refine those kind of things. So if you've done so much of good work, don't allow it to go waste.
Yeah, actually my team is sitting over here. They have worked hard for all these things, planning all
As
these
they
blocks.
put it down on paper.
Yeah.
Most of the teams are good in working.
Yeah.
They're not so good in publishing.
Yeah, yeah.
So I would like to really tell you
Yes.
that publish it, you
Yeah.
know, or publish it or write it down. Okay.
Yes.
I mean, this is the point I want to make it very.
Yes.
Time to close it.
Yeah. Actually, we wanted to ask so many questions. We wanted to have a discussion even on skills training. But since we are running short of time, we will, I would like to thank all the panelists and Priyanka.
you.
Okay. Any felicitation? Sir, felicitation. Huh? Sir, be seated for a minute, sir. We would like to, yeah.
We would like to felicitate our panelists, Dr. Supe sir, by Dr. Gade, Shubha Gade ma'am, Gaidhane sir, Dr. Gaidhane sir. I request
the moderators of this panel discussion. I request Dr. Abhay Gaidhane to felicitate Dr. Lata Ravichandran.
I request Dr. Ujjwal Gajbe ma'am to please felicitate Dr. Purnima Barua. I request Dr. Shweta Pesurkar to felicitate Dr. Sahiba Kukreja. We will have a we will now have a short break of only 20 minutes because we are already running behind the schedule. So we will break here for lunch and then we will gather in auditorium hall for the inauguration purpose.